Board meeting 2022. I'm going to call this meeting to order. Before we approve the board minutes, let me make sure who's here and who's not here. All right, so Tom. Okay, so Bob's here. Susan Ricky Smith. Susan Miller is here. Hi, Susan. Bonnie. Okay, Bill is here. Enrique. Okay. Michelle. Jeff is here, and I see that JJ's here. So I don't know if we have a quorum, do we?
You better come back to do minutes after their board member arrives.
Well, then that would require us to skip the next piece too, which is introducing the two new members. Oh, Enrique's here.
How many total members? Because we can't even approve minutes or anything without a quorum.
Right, so.
We need 6, and yeah, you've got 6.
3, 4, 5. Yes, we do have 6. We have 7. So, all right. So we do have a quorum. Rose had sent you the minutes from last time. Hopefully, you've had a chance to look at them. When we've had the opportunity, given enough opportunity to look at them, I'll entertain a motion to accept the meeting minutes from February 1st, 2022.
Move to approve.
Second.
Okay, so I think that was Bob and Bill seconded, is that right?
Correct.
Okay.
Correct.
All in favor of accepting the February 1st, 2022 minutes as written, say aye.
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 Any nays? Okay, well, the minutes are approved once again. All right, so we have some good news. We do have some new board members. I think we're almost fully staffed at this point. We have Enrique and Michelle, and I don't have bios on either one of you, although I do know Enrique. Enrique, would you mind just briefly introducing yourself for the rest of the board? And we'll hopefully soon we'll be able to meet in person.
Well, thank you, Chair. Good afternoon to the board. It is my pleasure and privilege to be here and learn more about your work since I follow up from afar. Currently the Vice President of the Oregon Education Association. My educational background or professional background is at Clackamas Community College, where I serve as a full-time academic advisor on leave right now. I previously, as last week, served at the HEC, Higher Education Coordinating Commission, as a full-time commissioner as well. And I'm here. I graduated from Portland State with a bachelor's degree in anthropology and a master's in policy and education. And I look forward to learning from you and all of you and how we can serve educators across the state. Thank you.
And thank you for Enrique for agreeing to be part of the board to help us make the decisions that impact thousands and tens of thousands of people. Appreciate it. Is Michelle here? Ollie, does anybody want to say anything about Michelle, or should we just wait until next time?
Yeah, I'll follow up with Michelle. I actually met with her a couple days ago, and she just must be running late, so we can just follow up when she gets on.
Yeah, let's loop back. That'd be great. Okay, the first piece of our action agenda today is a request to approve to file as permitted rule with the Secretary of State. April?
Hello, can everybody hear me okay?
Yep.
Yes, just fine.
Great, awesome. All right, my name is April Kelly. I am the Program Benefits and Services Coordinator with Kevin OEBB. Oh, I have some feedback, sorry. Okay. And so I'm here to present some rules that might look familiar to you. You saw them at your December 7th 2021 board meeting, except for the new board members. Probably this will be your first time reviewing these rules, but so for page 7 in your PDF packet, if you're looking at that, or Rose, the lovely Rose has them there on your screen. And these are our Division 10, our definitions division. So just briefly, we do have some housekeeping amendments that we've identified in there. But the main reason that we needed to amend these rules was due to the expansion of the definition of a disabled dependent that was brought out of the 2021 legislative session, Senate Bill 748. And we did take these through the rules process. We opened them up for public comment. We did not receive any public comment. And we held a rules hearing. And so we are back here requesting your approval to file these permanent with the Secretary of State's office. Does anybody have any questions? Rudy's on mute.
Well, April, I think I'm just giving everybody a chance to just thumb through the
Sure.
changes, the strikeouts
Absolutely.
and the underlines.
Yeah, great, thanks.
Are there any questions for April on any of the proposed changes?
This is JJ. I move that we approve to advance to the next step.
This is Sue Ricky, and I second that.
Okay, April, is this motion to adopt the rules as permanent? Is that the way I should phrase that?
Yes, that's correct. Yeah.
Okay.
So amended.
All in favor of adopting the proposed changes to the Division 10 rules as written, please signify by saying aye.
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 Any nays? Okay, the motion carries and the changes have been adopted.
Great, thank you. I
Okay.
appreciate it. Thanks.
Anything else, April?
Nope, that's it. Thank you.
Okay, good seeing you.
Thanks.
All right, thank you. All right, so next up, Matt and Brad are going to talk about OEB Wellness Program renewals and diabetes prevention and the EAP, all in 10 minutes.
Good afternoon, OEB board. This is Matt Sendersky, a health management consultant with WTW. Excited to be here again today and sort of pick up the conversation where we left it off at the last board meeting. What I think that we can do just to expedite time, and since we went through some of these slides previously, is if who's ever driving, I think Man Rose, if you can go ahead for this slide back here and just push ahead to slide number 7. Because we covered a lot of this information on the previous slide or the previous board meeting. So I think just in the interest of time, we can go ahead and start here. And one of the things that I wanted to do for the OEB board today is that Glenn and I had an opportunity to connect yesterday. And Canary Health, we had shared some of the feedback that we had with Canary Health, and they reached out and they said, hey, we just want to clarify some numbers or some things here on this slide that we want to make sure that the board hears. And so I want to make sure that we communicate it with you and be very transparent here. So if we take a look at their Better Choices, Better Health program. So one of the questions that we had is on our renewal here with Canary Health. If you recall, they've sunset their diabetes prevention program in Q4 2021. So that will no longer be offered to OEB members. And so the question was, what do we do with their Better Choices, Better Health program? And so we brought this to the board during the last meeting, and I provided some updates on their current engagement numbers. And it must have been I must have pulled like a Q3 engagement report. I went back and I took a look at the information. And so Canary Health provided me with some updated numbers yesterday. So total, they had 335 participants registered. So up from 307. They had 201 individuals show up, and they had 71 individuals that had completed their session. So I think in the Q4, they must have had a lot of people. Probably it looks like another 31 people from what I originally reported, or a little bit less than that, that have completed their sessions. So wanted to make sure that the board had that information. Also, just to reiterate to the board, what Better Choices Better Health is. This is a small peer group support network that individuals get plugged into, where they have these workshops that are not really clinically focused or specifically focused in an area. The individual pretty much gets to have support in the area that they think that are important to them. And then they sort of use motivational interviewing techniques and things to bring the person along the stages of change. So while they did provide the updated utilization numbers and we wanted to share them with the board, it does not change my opinion of our recommendation on what OEB should do here moving forward. The engagement is still not at a level where we feel that it should be. And also one of the main components of the program that I think are missing here is that it's not a program that's really designed at helping people reach outcomes, right? Reach healthy metrics. And so we think that, OEB should still consider discontinuing the relationship with Canary Health and look at promoting the other resources to OEB members that you have at your disposal, which would be the WebMD1 program, the WW program, and then the health improvement programs that you have through MODA and Kaiser and those disease management programs. So just wanted to revisit that before we moved on to the new business. Was there any questions, comments, or concerns before we move on?
This is JJ. We only have 0.5% participation, and to me, that doesn't have enough ROI.
Yep. I would agree, and that's why I wanted to present the new numbers. But to that point, I still don't think that they're in a way that we really want to take another look at this. And I think that you have other resources there that we can direct people to that would have more impact in your population. So if there are no additional comments, we will continue on. And then Rose, if you can go ahead to slide number 13, please, because again, we covered a lot of these slides at the last one. So we went over this diabetes information during the last board meeting. And so what I'd like to do is pick this up where we're at. And I see a hand up there. Sorry, Jeff, if I missed you there. Go right ahead.
No problem. Question for Robert. Do we want a motion to discontinue Canary Health at this point, or is that later?
I was going to ask Ali the same question, but I think if Matt has a package recommendation, we can just do it all at one time, or what do you think, Ali?
Do you have a preference, Matt? If we can go either direction.
I think since we're going to take these piecemeal throughout the meeting, if we want to do one, and then while it's fresh in everybody's mind, we want to do the vote right then, because I don't want to continue on to these additional ones and have people think, well, what did we, so I think we should just do it as we cover the different topics.
Okay, so moved.
This JJ,
Okay, we have a motion and a second to discontinue the remaining Canary program. All those in favor of the motion say aye.
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 Any nays? Okay, the motion passes. So Ali, if you could let Canary Health know that.
Yeah.
All right,
Okay.
Matt.
All right, great. So moving on down to the diabetes prevention program portion of our presentation. If you recall the last meeting, we had some initial discussions just regarding MODA's Pre-D program and then their program that they offer through a third-party vendor, Livongo, for MODA members. And some follow-up questions just came regarding, okay, well, now that we've taken a look at the MODA population, we understand that Kaiser has a DPP program, and then Kaiser also has a relationship with a third-party vendor called Omada Health, which you may be familiar with. So one of the things that we were tasked with and our takeaways from the last month's board meeting was to sort of build out this scorecard and plug in the additional data points, and then bring this back to the board for an opportunity for us to review it. And if you take a look at the scorecard here, you can see where the MODA Pre-D program is. And we had an opportunity to touch base with the MODA team. And what they did is you take a look at some of those areas with the circles in them. You can see where what they've said to us is that, hey, we currently don't have these things in place, but they're on our roadmap here in the near future. So if you can see the things like register with the CDC as a DPP, build up to moderate changes that result. So your outcomes 5 to 7% weight loss. You can see weight participants at each section, and then complete 22 of the 26 CDC DPP approved learning modules. So you can see those are things that they're going to be adding to their program as they continue to build it out. The Livongo program, you can see that one is fully vetted. It's a fully plush resource that's offered in a DPP solution. And then you have the Kaiser DPP program, and this was information that they provided us on their renewal that we pulled out and we put into this deck here. And you can see that there's certain things that they do not have, and they're not planning on adding these things to their roadmap. So Kaiser does not intend on having their program registered as a CDC with the DPP with the CDC eligibility questionnaire. They do have some really strong components, which we're going to talk about their program here later on in the slide decks, that they have their weighing participants at every section. And then, of course, the modules. Kaiser has their own internal curated materials as it relates to metabolic syndrome and diabetes, which they offer to their participants. And then you can see the OMADA program. And, you know, I think for the folks here that are on the board, if you're not familiar, Livongo and OMADA are very similar programs. They have the remote monitoring where people have the opportunity to upload their blood sugar levels, and then they get downloaded into a database where they can track over time. They have the health coaching, and then the online digital tools, the recipes, the nutrition programs, the different things that support people along their journey to help control their blood sugar levels. So any questions on this slide here before we move on down the presentation?
I have a question.
Yep.
Enrique. Mr. Chair, there's a question on the chat, and I would like to get some clarity if there's a discrepancy on the numbers presented. I think for full transparency, we need to answer that question on the cost of the program. Thank you.
Yeah, I just answered it in the chat, and you know, I think that was between Jonah and Willis Towers Watson on the cost of the program, but that's the first I've heard of the discrepancy, so we can work that back through CL. Unless Matt has a comment on it.
Yeah, we can certainly go back and revisit. I know that they had provided updated numbers, so if we want to revisit it, I mean, I still think that for the board and OEB, what the goal is to implement a program that has high utilization that drives outcomes. And so I think that it doesn't, you know, we can go back and revisit that number, but it still doesn't change the overall outcome, I think, of what your goal is with a health management program.
Thank you. I appreciate the clarity. However, for full transparency, I would like to have the right numbers being discussed. And even if they made outcomes or not, I think people need to know. Thank you.
Okay, sounds good. We'll be happy to get those numbers and share them with the board. Okay, any questions on this slide before we continue on? Nope. All right, we want to go to the next slide here. And so this is just the built out of the capabilities for the diabetes prevention programs that are offered by the different carriers or the different solutions. You can see again that we start with the Moda Pre-D program and then work ourselves left to right, Livongo, Kaiser DPP, and the OMADA for the Kaiser members. You can see where they're currently at with the effective communications. Moda Pre-D program is still developing their communication strategy for that. So we'll be able to provide that information to you once we are given it. You can see the incentives that are provided among the different programs. You can see Kaiser's is the one that where there's no incentive that's provided to the members. You can see the engagement, performance guarantees, Livongo and OMADA. Engagement outcomes. So Livongo and OMADA, they really stress those in third-party vendor. Outcomes tied to milestone achievement. You can see that 3 of the 4 are currently administering that. The Kaiser DPP program does not have that. Coordination with the PCP or specialist. And this is where we would really see that the carrier programs would excel. Your Moda Pre-D program and your Kaiser Diabetes Prevention program, as they are integrated into the health plan, you are going to have better coordination with their primary care physician or their specialist in implementing that program. Reporting of outcomes, you can see where the different solutions come back with that. And then the cost, you can see where they have the cost there. for the Kaiser DPP program is built into the base premium. And then we have a slide that we're going to jump to next, which goes a little bit more into pricing. But really with your pricing, you want it to be based on achieving different milestones. So as the people go through the different modules of the CDC diabetes prevention program, then the individuals achieve a milestone, and then they're billed per their progression in the program. And then that milestone achievement is tied to outcomes and weight loss. So any questions on this slide before we move to the pricing slide? No? All right, Rose, if you can go to the next slide, please. Okay, so here's the pricing sort of built out, flushed out, so everybody has a good idea of the annual cost for these programs. Moda Pre-D, Livongo, Kaiser, and Omada Health. So what we did here is on the top is we listed the core components that participants would receive if enrolling and participating in each of the programs. And then you'll see their per participant cost. So let's start right here on the left for Moda Pre-D. The total annual cost per participant if all milestones are achieved in 12 months. You can see that the year one cost for individuals is right around $1,400. And then there is a decrease in year two just due to the amount of milestones that a person would be hitting in year two of their program. So then if we take a look at the estimated annual cost, individual participation, and these were numbers that were given to us by Moda based on what they assume they'll be able to engage, because you only get charged for the people that qualify and engage in the program. And I think, okay, there we go, cool. Charged for the people that engage and qualify for the program. So the year one cost for OEB would be $1.6 million. And then the year two cost, you would see that drop a little bit based on participation and based on the total cost of the program to $0.5 million.
Yeah, and hey, this is Brad. I think it's worth pointing out just a couple little things in there. You know, back up at the top, you can see that there is an additional upfront cost in the Moda program, a little tiny one for testing, and then a little bit larger one of $250 for what they call sort of an onboarding. And this is as the individuals go and they sort of fill out their documents and you know, get registered in the system and everything. So OEB is charged $250 once they become fully registered in that system. And then every quarter, if they engage with a health coach, they have one quarterly meeting, then they are also charged that $250. And so that's really the difference between the year one and the year two cost. The other difference in there too is that Moda does require a nutritionist visit, and we've estimated that cost. You can see that in the footnote. I'm sure that cost would vary depending on which provider they went to, but we've just used a high level estimate of about $150 that would be charged to the OEB plan through the claims system, not through an administrative cost.
Yep. Thank you, Brad.
Mm-hmm.
So jumping on over to the Livongo for the Moda members. So you can see the core components of the program, which we just discussed in the scoring grid that we have above. The total annual cost per participant is, if engaged for all 12 months, year one would be $708 per participant per year. That breaks down to $59 per participant per month. And then with, just like similar with the Moda Pre-D program, for the Livongo Pre-D program, if people are enjoying the program and they continue on for year two, they can still stay with the program and get the services and solutions, but they would receive reduced pricing. And so you can see that year two program cost drops down to $348 at $29 per participant per month. So using the same participation numbers that Moda provided us for their Pre-D program, you can see 1676. You can see the year one cost for OEB would be $700,000, 0.7 million, and then year two cost, that's going to drive down to $0.2 million, $200,000. And Brad, I don't know if you go right ahead.
Yeah, I think it's also just worth mentioning here that we have used the same participation rates for the MODA pre-D program as for Livongo, just for really ease of comparison purposes on the total dollar amounts. But it is worth noting that Livongo does estimate a higher participation rate than the 1676 individuals per their sort of book of business experience. But we've used the same numbers just for comparative purposes in here.
Yep.
So Matt, can I ask a clarifying question? So
Sure.
if we approve the MODA pre-D program, will Livongo still be there and they're competing for clients, if you will, or if there's MODA pre-D, is Livongo going away?
Yeah, and I know that we have some MODA members here on the call, so please, or on the board meeting, so please chime in if I get this wrong. Hey, Erica, how are you? But I believe
Thank you.
I believe right now the Livongo program that's in place for the OEBB MODA members is just their diabetes care program. It's not their DPP program. So what you would have is you would have the MODA Health Livongo program for diabetes care management, type 1 and type 2, and then you would have the MODA pre-D program for your diabetes prevention participants.
Yeah, so no crossover or competition.
No. This is Dr.
Yeah, thanks
Popovich.
for the clarification.
Matt, you're spot on. That's exactly right. They are two very distinct programs.
Yep, great question. Great question. Okay, so moving on to the Kaiser Diabetes Prevention Program. You can see the core components of that, members identified through lab results and claims data. So this, just like the MODA Pre-D program, would have more integration into the health plan network. You can see the 6-month virtual classes, health educators and dietitians, health coaching services, weight management classes, and then engagement and outcomes reporting they do have available. The cost for this program is included in your Kaiser medical premiums. And so for the per participant cost and the estimated annual cost, that's already built into the Kaiser rates.
Yeah, I do want to also say, while they do have engagement and outcome reporting available, I want to say that there has been some challenges, maybe from a systems perspective, and I'm sure Kaiser could speak up on this as well. But I don't know that we've really been able to get a full reporting package from them yet. But it is in the works, is my understanding.
Yeah, that is correct. And I don't know if Sophie or a member of the Kaiser team is on the board meeting if they want to chime in, but I think I read an email, Brad, late last week that it's on their roadmap for like Q4 2022 for outcomes reporting from their diabetes prevention program.
Oh, and they're sorry.
Yay.
Hello, and yes, you're absolutely correct. We have been in the midst of building our actual pre-diabetes program into our health record system. It's been almost a 2-year process, and our target is by mid 2022 is to report the outcomes on our book of business data. So we don't have it yet. However, it is in the planning process.
Awesome. And then the final solution that we wanted to bring for the board to review today is the Omada Health solution for Kaiser members, which is very similar to the Livongo. It is utilization of a CDC prediabetes risk screener along with age and BMI to confirm your eligibility. So it's not built into the claims or the integrated health system. That's how they're designating people and doing outreach. You get a pre-connected scale. You'll be matched with a dedicated Omada health coach. You do get the cellular CGM, so the cellular glucose monitor. Online peer groups, interactive lessons, and outcomes and reporting. The per participant pricing that Kaiser has shared with us is around $500 per participant per year. And so we just did some estimated analysis just based on the MODA population, the OEBB Kaiser population, and flushed out so 30% of your population would be eligible, and then of that 30%, 10% would enroll. So we use some pretty conservative numbers there around engagement to provide us with a total estimated annual cost for the Omada program of $447,943. And Safari, do you want to provide, I saw some emails back and forth last week, just providing some context. I know that you have, just from like a global perspective, you have the Kaiser diabetes prevention program and the Omada. Do you want to talk a little bit about the engagement with each or provide some commentary around that?
Sure. Thanks, Matt. I'll ask Dr. Bachman to join me also for his input. But just wanted to clarify that the Kaiser Diabetes Prevention Program and the OMADA program are two programs that are addressing pre-diabetes. We do feel that the OMADA program is an additive program to our services. So our program definitely follows the CDC guidelines for a diabetes prevention program. However, OMADA just has more of that. Their program has more touch points with respect to the virtual component. We have another big account that uses OMADA. We have OMADA on, several of our large accounts nationally, and the OMADA participation for our large group that I'm referencing tends to be a bit higher than the Canary program that we were using. So in addition to that, I also want to mention that having the diabetes prevention program in addition to our existing program, it doesn't mean that members could choose one or the other. We definitely, OMADA, if we had OMADA for OEB, they would definitely do their outreach to try to gain participation. However, for our Kaiser own internal program, we still give members the options. They could either use the Kaiser DPP route, or they could also go to the vendor route. Dr. B, did you have any additional comments?
No, I do just a couple things. One is that diabetes prevention and prediabetes care is integrated into our whole system, from automated alerts when we should be screening for blood sugar, it hasn't been done, to decision support related to sometimes use of medications to lower blood sugars when people are at very high risk, and engage people with health education programs. We don't just have a DPP program, we also have health coaching available for people that aren't sure what the next step is, as well as sort of a what is prediabetes webinar that happens at least monthly. So there's lots of different things there. I think the other advantage of the local program is the integration with primary care, integration with somebody's medical record, and also from a diversity or language perspective, if people had issues or concerns, needed a culturally adapted program, or say somebody was hard of hearing or had visual impairments making it difficult to participate in a web program, something like the internal program would be able to adapt for that. Health equity, we in conversations with the leadership of our health education and wellness program, they just talked a lot about health equity and making sure their programs were accessible to all of our members. Not that OMADA's not, but just when we know people and it's local, we can definitely be right there and involve them in their necessary journey. So we think these are both good programs. Both have advantages for an individual, and we think providing choice is the best way to go.
Enrique, did you have a question?
Yes, sir. I do have a question. My question is, if you're a Kaiser member and you get a blood work and you are, your blood work comes back as like pre-diabetic, or you have history of diabetes in the family, which tends to be with the African American community, the Hispanic community, which is a high number of diabetics in the population. Do these people get automatically referred to this program, or do they have to volunteer, or the provider or the physician says, hey, there's this opportunity for you? I just feel that on the, patients, who are not used to advocating for themselves to have access to these programs, how will people will have access to this without even not knowing them? Thank you.
Yeah, so when prediabetes is detected, particularly the first time, kind of the standard language in the lab results would be to recommend somebody discuss the findings with the health coach or back with the PCP to come up with a plan for it. Now, not everybody does that. And certainly when we recheck the sugar level in a year or 2 or 3 years and we see it's gone up even further, we're going to kind of reiterate that as well. So we diagnose this a lot. Not everybody is ready and interested in making a change. A lot of people are ready. The most common thing is somebody feels they can do it on their own and make a change, but we definitely support them in the path. Does that help? It's not super tight, but it's not super loose either. So as long as people follow the protocols, if the physician puts the right code or the right links into the lab result report, and if they follow the right prompts to test on the right people, it all guides the care in the right direction.
Awesome. Thank you.
Yeah, Enrique, and that's a great call out. And that's one, I think, the advantages of utilizing the carrier resources, that it's integrated and you have that opportunity to use claims data to make outreach to participants, to make them aware of these resources that are available to them. So I think that's a great call out. Any other questions on the pricing slide before we move on down to the next slide? Nope. Okay. If we want to go to the next slide, please. Thank you so much. So DPP considerations, and then our sort of our final recommendation that we have here. So third party versus carrier solution. So what are some of the benefits if OEB wants to take a look at partnering with a third party DPP solution? So both the DPP solutions, the diabetes prevention solutions that were put in front of you, Livongo and Omada, are CDC certified. They all implement all criteria of a CDC DPP, which were those things that we mentioned. They focus on engagement and outcomes. They utilize best-in-class technology, optimizing employee experience, your digital front door, your cellular glucose monitor, your online, tools and resources. They're fully vetted solutions with measured and documented success. And also, one of the benefits of utilizing your third-party vendors is that they have built-in incentives into their program for the participants. Now, what are the benefits of partnering with a carrier diabetes prevention program solution? Obviously, number one, the physician coordination. So they're integrated into your health plan. The individual is connected with their physician. It's very highly educated. It sort of keeps in that sphere of care. They integrate other health plan benefits. So we've talked about that. And the Kaiser individual just talked about the health coaching, the different things that's available, the Moda 360. There's a lot of things that sort of keeps them in their sort of their wheel of the different resources that are available through their benefit plan. And it focuses, and we've heard from the vendor, they're focusing on engagement and outcomes. So you do have some of that. It's just not as fully vetted out as your third party solution. So with all that in mind, and one of the things that I always like to do is I like to set up OEB for success with what are the solutions that can make a positive impact in your population. In the near term today, what are the things that give you the best opportunity for success? Utilization of a third-party diabetes prevention solution provides OEB with the best opportunity to make a positive impact among their pre-diabetes population in the short term. The carrier solutions are not CDC certified and are not proven commodities in this space. So we'll stop there. I don't know if we want to take, if you guys want to take a motion or a vote, or what the chair thought, but this wraps up our DPP portion of the presentation today.
Well, I'll be honest, I'm not entirely sure what the motion would look like at this point. So I might need a little help on that if we were going to go that route.
Yeah, and Robert, I don't know if you were looking at me to make that suggestion, but it sounded like at this board meeting, one of the decisions that you wanted to make was how do we want to move forward with our diabetes prevention program, understanding that Canary Health, their DPP program was sunset in 2021. So we don't have that Q4 2021. So we don't have that available anymore. So right now, the Kaiser population and the Moda Health population don't have technically a CDC certified diabetes prevention program that's available to. Do we want to take a look at integrating one of these carrier options that are available through both Moda and Kaiser? Or you could take a look at going the route of Moda's pre-D program, which they're currently developing and have that available to you, and then leveraging the resources Kaiser's diabetes prevention program, which they have in place. And so, after going through all the information and taking a look at our analysis and gathering all the data from the different vendors that are available to you, my recommendation would be to take a look at your third-party vendors here in the short term.
Okay, I'm going to go ahead and open this up for discussion. Michelle, hi.
Hi, everyone. And I'm sorry, this is my first meeting. So if this
Oh.
has been covered before, just let me know. But I'm just curious. It says on the slide I'm looking at that fully vetted solution with measured and documented success. But what is the documented success? And have we seen outcomes that show that these programs actually prevent diabetes from developing?
Yeah, that's a great question. Michelle, correct?
Yeah.
Yeah, Michelle, that's a great question. And if you take a look at Livongo, or if you take a look at Omada Health, these are third-party diabetes care management solutions that have been in the market now for several years. They have white papers, they have case studies, they have ROI analysis. They've been fully vetted by several different sources. And, we can pull that information and we can share that with you and you can take a look at it. I mean, it's part of one of the reasons why you would take a look at one of these third-party vendors. I mean, they're willing to put some of their fees at risk based on these outcome ROI metrics. And while the MODA Pre-D program, it looks great, it is a new program, right? So it is currently being rolled out. So when we say that fully vetted solution with measured and documented success, that's what we're referring to.
Thank you.
Yeah, did that answer your question?
Not really.
Okay. Well, I think there's, and that's why I asked that question, because I had a feeling maybe that there was just a little bit more to chat about on that. And I think maybe a motion might be to say, hey, we've looked at these two different types of solutions at a high level. We have, and all of them have a lot of potential. And, we took a little bit of time and we chatted with Tom Siltabo, who's, the physician representative on the board. And he had a really good comment. He said, the thing that we really want is we want engagement. We want a fully built out program that meets all the requirements. And the CDC, whether it's exactly the right or best program or not, really does provide sort of a little bit of a roadmap for the program development. And I think that's, one thing that the board, from my understanding of these broad ranging discussions, sort of has zeroed in on a little bit. Both the PEP board and I think OEBB was starting to lean that direction. Based on what we've seen, I think maybe one of these, a decision point could be, hey, do we want to explore these carve out, but still integrated? The vendors already have partnerships with them. Do we want to explore maybe that a little bit more, because we can go through and document, hey, here's what their book of business has achieved from an engagement perspective. And we can even dive in a little bit further and say, here is their methodology they use to engage people, their communication materials, their screening process, and what have they done? What are the studies that have been done that say, hey, can you keep somebody from getting diabetes? And those are all things, I think, as what Matt was saying, is that because these vendors have been around for a while, there are documented studies on those things. We haven't included them, with a lot of detail here, but I think that would be a really good next step, is to get some of that material if we're interested in going that direction and saying, hey, yep, Livongo has, they're saying they can get over 5% engagement. And not only are they saying that, they have done that with a number of clients, and here's kind of how their book of business works. And by the way, if they don't, you don't have to pay for, a fair bit of it. So they're willing to sort of put their money where their mouth is from a revenue perspective for them. Does that maybe a little more help to answer that question?
Yeah, it's helpful. I mean, it sounds like the outcomes are more around engagement than around actual health outcomes, and so.
Well, they do have outcome reporting as well that
Okay.
they can share from their book of business. Yeah, so I'm sorry, but yeah, both engagement and outcomes.
Okay, Jeff, and then JJ.
I'd like you to spend a little more time or expand on setting this within the context of a coordinated care model. You have a bullet there, but I'd like to hear more about that.
When you say the coordinated care model, Jeff, which bullet are we taking a look with the health plan?
Integrating with other health plan benefits. Because
Yeah,
we're expanding the whole dialogue with a care coordinator. We've been promoting that, and it's really helpful to be able to interact with the primary care physician, and when we're talking diabetes, an endocrinologist. So I'm kind of going, if they're in development, maybe we need to study a little bit more, but the potential benefits there as opposed to a freestanding program that may not be integrated. So we lead to information, but we don't necessarily lead to changes in care.
So Jeff, that's a great question. And I think the best people to answer that, Erica, I don't know if your team from Moda Health want to provide a little bit more insight on the plan with the pre-D program to the integrated of the healthcare benefits as it relates to the pre-D program. I know the doctor from Moda chimed in. I think that they would be great to provide some insights, additional insights on that.
Yeah, and I can start this off and then let Dr. Popowich jump in. But, you know, that's a really great question. And I do just want to say with our Moda 360 platform, even with the Livongo program, we will have the data integrated where we can see the touch points and get the member connected. So there is still a level of integration even with the Livongo pre-D program. With the Moda pre-D program, that integration would be more, and it is integrated into the plan a little bit more than Livongo would be. And that's done in a couple of different ways. So first, I think one of the differences between the Moda program and the Livongo program is that initial screening. When you look at prediabetes, we know that there are certain number of members that we can identify as being in that pre-diabetic category and level, and we use our claims data primarily to identify those members. So those members we would be outreaching to already to try and get them to engage in the program. But we also know that there's a lot of members out there who do not know that they have prediabetes and who we don't know have prediabetes. And so that's why the first step on the pre-D program was to incentivize members to actually take the CDC survey that gives you a score and identifies if you're in the pre-diabetic range or not. And so then for those members, either it's you're great, you're doing great, you don't really need to engage in the program if you don't wish to, but the ones that we identify as qualifying, then we would get them engaged into the program. And so when we do our onboarding that Matt talked about, that onboarding involves having the member meet with a health coach. So it's more than just getting them signed up for a program. It's actually going through all of their risks, and it's getting them connected to the nutritionalist, because we think that one of the an important first step in the program is for the member to actively engage with the nutritionalist to get started on the program. So the health coach that they work with initially will help them get connected with that appointment. And as part of the program, the cost sharing for those nutritionalist visits is waived. So the member wouldn't have any cost sharing for those visits. And then after they go to the nutritional visit is when they actually come into the program, and we get them set up on the Fitbit. On the Fitbit is where we are getting actual data on the member. So the Fitbit, as I'm sure everybody knows, manages or monitors activity levels. So that's data that we're actually getting in from the member. And then it also allows the member to input their weights when they're taking their weights. And so then that's also information that we're getting in from the member as well. Another way that we're engaging with the health system differently than the Livongo would is that we, as part of our program, we'll start with the clinics that we have a large number of OEBB members with and do pilots where we're actively engaging and working with them to identify the members who are pre-diabetic and then get them into the pre-D program. And then also just the reporting that pushes out to the providers, letting them know who we've identified as being pre-diabetic. Some of that will already happen with the Livongo program, because as I've said, Moda 360, that's already built into the Moda 360 program. But the pre-D program, as I hope I explained a little. It's a little bit more coordinated with our providers. Dr. Popowich, did you have anything else to add to that?
I think you summed it up really nicely. The only other thing I would add is that we know that incentives work, especially when it comes to trying to initiate and implement behavioral change. And one of the nice things about the Fitbit Premium program that we've worked with Fitbit to create are incentives that as members reach certain milestones, whether it's with weight loss or activity levels for a certain defined period of time, there will be incentives. And I think that's that's something that Livongo does not offer. And knowing that we can control this information better, I think that's why we think we could do a better job in-house with a program like this than a third-party vendor.
I have another question, but I'll yield to JJ first.
Thanks, Jeff. The other question I had is, we have some hard costs, but I'd like to see that in context to how it affects rates.
Yeah, I'll let Brad take that question.
Well, so I mean, there's a couple different things. One, you have the upfront program cost, and I think there's a number of different ways the program cost could be, paid for by OEB. With Canary, it was being paid for out of the administration fees. This program is substantially more expensive than the dollars that were coming out of the Canary program, partly just from a per participant basis and partly just because Canary had such small engagement. So I think that you could do that and that would be fine. We've also, on the flip side, you could add that to the premium rate, which probably isn't the best way to go given our constrained environment. One of the things that we have talked about as a board in past years is ways that we can use the RSR funds out there. And one of the things that we had proposed using RSR funds were for wellness activities that have the potential to provide kind of ROI going forward. This is a program that we feel, if implemented right, engaging the right people and, having some good guarantees on outcomes and engagement can drive some savings ultimately for future claims. So, I think it has the potential to not impact the rates directly if it's funded through RSR, but to potentially in the future yield some claim savings and positive outcomes. Does that answer your question, JJ?
Yeah, and the other thing is really our options are do nothing, pick one, or pick both, both for Moda and Kaiser. And some data on pros and cons of those choices would be helpful. And I know we're a little constrained on subcommittees, but typically those types of deep dive is done in CL.
Yes, correct. Yep. And I think, one of the things that formulated our recommendation right now is that, the Moda program, while we think there's a lot of good potential and it sounds really good, it's just frankly, it's not built yet. It's not complete. And so there's still a lot of questions out there about, will it be able to be done in time? How's it going to function? There's no piloting, out there. And if we really need something that's a plug and play, Moda does already have a relationship with Livongo, and and they're a great vendor. Moda wouldn't have chosen them if they weren't a good vendor. And the same thing with Omada and Kaiser's relationship. They are a little less expensive. Perhaps you're not getting quite as much integration out of that, but we do feel the Moda 360, navigation structure will have more engagement and more potential than you would get in a regular carve out situation. So I think that, even going with a Livongo plan, you'll probably get more benefits from that plan than you would if you did not have the Moda 360 in place, more integration in there. So kind of when you start lining those pieces up to say, hey, it's in place, we need something now, it's already got the CDC certification, it's lower cost, we do have some integration advantages that will be done through Moda 360, kind of start adding those pieces up and it says, well, that seems like a good direction to pursue. And then, you know, that's not to say that in a year or two, if MODA has their program up and running, I think it'd be well worth piloting that, you know, in some cases to see, hey, how is that working? You know, let's check some results out. And I wouldn't be afraid to make a change at that time if the data was showing better results or outcomes.
Okay, my second question. Obviously, a program under development doesn't have the data, but in existing programs, are we able to separate the engagement rate between those that have been diagnosed with diabetes and those that are diagnosed with pre-diabetes? Because I strongly suspect there isn't much engagement on a pre-diabetes basis.
You know, I based on my work with Livongo and other places, I think it's fairly straightforward to do that because you're really targeting two very different populations.
Right.
And so I don't know, Moda, if you have questions, you know, or comments on that around, I think, you know, we could probably easily get that information from Livongo directly, or Moda could through their relationship, you know, as a vendor partner. We certainly have, you know, as a broader national vendor, we have that information too, and Matt could grab that for us pretty easily. But I would say from an engagement perspective, I think, you know, my understanding is there's still a fair bit of engagement out there on the pre-diabetes side as well. So, and certainly on the diabetes side higher. But
I'd like to see some data on that.
Sure, we can grab some data for you, Jeff. And, you know, one of the things I just wanted to rehash here before we wrap this section of it is that, you know, Erica did a great job talking about the process that individuals will be brought through as they are introduced to the MODA Pre-D program. It's a very similar process that when you take a look at a Livongo or a Omada with the initial screening, and then the individual comes in. At that time, they're connected with a health coach. They have their initial assessment program. Then at that point, you know, if they continue on, then they're receiving an incentive, a scale, and different things to help them be successful in the program. And one of the things that I really like about Livongo and Omada is the cellular glucose monitor, and for Livongo, the blood glucose meter that they're getting to help track their results, then feed directly into the coach.
Well, the glucose monitor is only for the Livongo diabetes program, not their Pre-D program. Their Pre-D program is only a digital scale.
Sure. Yeah. So they would have the incentive for that. But if they did with that, then.
Hi, this is Jonah Kaufman from Canary Health. Just from our perspective in the history of providing our DPP program, certainly Kaiser members, because they were screened through the EMR and had to have the diagnosis prior to enrollment, certainly were all verified to have had a clinical diagnosis of prediabetes. On the MODA side, because we didn't have the integration into the clinical side, the CDC screener for diabetes risk seems to do a pretty good job of getting somebody who has all the risk factors, whether they have that elevated blood glucose to start, you know, is not verified. But certainly from our perspective, that should get the right sort of individual into the program. And then it is also my understanding that the ones that are integrated with the diabetes management program would not allow you into the DPP program if you have been diagnosed with type 2 diabetes.
That's correct. Thank you, Jonah.
Jeff, did that help to answer your questions?
I think so.
Okay, I think that's, I've got that down in notes as a takeaway that we can get some engagement statistics from the carriers on those two different populations.
I just want us to have reasonable expectations about what a program can actually accomplish. And I'm kind of operating on anecdotal information, but I find a lot of pre-diabetics to be in denial.
Yep, that's fair. And
so,
sorry, go ahead, Rob.
Go ahead. Sorry.
I was just going to say one final comment on that. You know, the carriers often have, you know, strong incentive to report accurate information, and we know that all vendors and carriers are stretching and reaching and want to show the best, but they do put performance guarantees in place that do put their fees at risk for things like engagement statistics. So
Well, the development of the newer platforms where it's integrated, carriers are in a pretty good position to push that a bit stronger. I think.
So I have
That's
a
my 2 cents.
clarification. I have a clarification question maybe for Ali. If we end up not making a decision today and we postpone it till next month, how does that affect the timeline?
Glenn, can you answer that?
Well, in regards to the DPP program, it would depend, and I don't think we've gotten to the issue of whether this would be included in the rates or the RSR. I think that in regards to the rates, it would need to be done, probably today, unless Wells Towers Watson disagrees in regards to the current schedule for the renewals.
In the RR funds, so that would make it part of the 3.4% for premium. So you have some additional time if the board's not ready to make a decision today. But go ahead, Brad.
I was just going to say, if you use the RSR funds, that would take it out of the 3.4% calculation, or if it's paid through on the administrative side. As far as from an implementation schedule, I think if it's not going into the rates, I think that probably gives us a little more leeway, but I would look to both Moda and Kaiser to verify that, from an implementation standpoint. And I guess I would also ask the question, if that is a program that needs to be implemented at the beginning of the plan year, or if that's something that could be implemented at some point mid-plan year.
Yeah. Speaking up, I like the idea of using RSR.
And I think that would probably be our recommendation as well.
Good.
Well, I guess there are multiple issues to vote on, I guess, is whether or not to accept any or all of the 4 plans. And then the second piece would be, how are we funding those plans? Am I capturing that correctly?
Correct.
Yes.
Okay. So I'll entertain motions on it. I personally feel like this is, never mind, I'll entertain motions on this.
I move that we delay the vote on this until next month, when we've actually seen some of the hard numbers that show return on investment of the various options.
Second that.
Okay, we have a motion and a second to table all decisions until next month, when we have more data to work with. That capture it correctly, JJ?
Yeah.
Okay. All those in favor of this motion signify by saying aye.
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 Any nays? Okay, so I'm pretty sure it passed. The only reason I paused is because I only heard like 4 people say anything. So that's what gave me pause. It could be that we didn't do we didn't unmute in time. So if I could just get a confirmation of the vote with maybe, let's try it again. So just because I didn't hear it quite. So all in favor of tabling this until next month, say aye.
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 Okay, that's better. And any nays? Okay, the motion passes. We will revisit this at the April meeting.
Hey, Ollie, are we
Okay,
able to
Matt.
have, by next month, are we able to have a CL meeting where they potentially could look at this next month?
Yeah, absolutely. And they already have really looked at this. But some of the questions that came up today, I think we can definitely bring back some more data and some, cost options. Like Matt said, it's a new program, so there's not a lot of data, but they're both good options. So I know it's hard to make a decision.
All right, Matt, are we ready to move to EAP then?
Yes, we are. Go right ahead, Rose. If you want to click ahead. Oh, go back up one more, I believe. All right. So looking at the EAP renewal through Uprise Health. And so just to reset the stage of where we're currently at in regards to your current term agreement and your utilization. For October 1, 2021 plan year, Uprise Health offered all entities who elect to offer EAP program 6 visits to a therapist at no member cost share. Previously, entities could elect a 3, 5, or 6 EAP visit model. So we've increased the session limits that people have through the EAP. Digital behavioral health coaching solution was added at no additional charge. So Uprise Health added the digital behavioral health solution at no additional cost. Overall utilization for the 2020-2021 plan year was down compared to prior years. Current utilization is up, likely due to the expanded visit availability. So if we take a look at the trends in the utilization from 2017 to 2022, you can see where we are currently at around 20%, then it dipped down to 16. Then we had a dip in 2019, 2020, down to 11.4. Then we had an increase, uptick in participation. We add the additional sessions up to 12.6. And where we are currently at here, with utilization for this current year. And then you can see the number of total services that are provided by the EAP plan for OEB members below. So any questions on this slide before we go to the next? Nope. All right, Rose, if you could please
Matt,
go.
actually, I do have a question on that. The 5.1, if we annualize that, what would it probably look like?
Yeah, I could crunch those numbers out for you, but I think that you're going to probably look very similar to the 2020, 2021.
Okay, thanks.
Let me make a note to flush those EAP numbers out for you.
Yeah, that said, I think your total visits will go up with the, expanded visit model.
Yep. So same number of unique participants, but more sessions because you have the expanded model. So then taking a look at continued, as we take a look at the EAP program, the renewal for Uprise Health, the preliminary renewal proposal, EAP fee 6 visit model and digital behavioral health coaching. So you can see the current rate. You can see the 2022, 2023 proposed rate. So you have a flat rate there. On-site trainings, which are optional. So you can see the $150 an hour. They're going to bump that up $100 an hour here for the renewal. You can see the resiliency coach and training, which is again optional. So it was $850 participant. They're bumping that up to $995 per participant for the resiliency coaching and training. And then the proposed additional service, which we're going to talk about here in further detail on the next slide, is a care navigation solution that they are going to be adding into your feature set for your EAP service. And this is what you see a lot of what they call your disruptors, your enhanced EAP vendors in the market today are adding these care navigators. So Uprise Health is going to be adding a care navigator for the OEB population, and the care navigator, Uprise Health navigators, will connect with OEB members digitally to encourage members follow recommended care plan, help them engage in coaching and counseling, book therapy sessions, and then help transition care to medical benefits when necessary. The proposed fee for care navigation is $1.85 PEPM in addition to the 90-cent PEPM fee, which would bring your overall total PEPM for your EAP services to Uprise Health to $275. So let's go to the next slide here so we can dive into this care navigation pilot and help sort of flush this out a little bit. So what we've encouraged Uprise Health to do, and what they're working with Salem Kaiser on, is a Uprise Health EAP care navigation pilot program. And this is scheduled to begin at Salem Kaiser in April 2022. And so what we've done is I had a call with their head of development, I think his name is Jay, over at Uprise Health, really got to understand this care navigation platform. They did a great job making themselves available. So we really understood what this pilot consisted of. Tanya, her team did a great job of sharing that information with us. Uprise Health agreed to pilot their new care Navigator solution for Salem Kaiser School District. Agreed to develop and provide frequent reporting to demonstrate outcomes. So what we want to see is if we implement these care navigators and if OEB assumes this additional cost, is it going to result in additional outcomes and additional people receiving care, access, quality of care. Features of the care navigation program. So this sort of just walking you through the process. Members seeking care will connect with the behavioral health care navigator. They can either click the chat phone line that will assess the member's risk level and direct them to the right resource for care, either coaching or counseling. High-risk participants will receive a call back from a mental health clinician in 2 hours. So this greatly increases their access and their speed to care. Low and moderate risk participants can start a chat with the behavioral health coach and schedule the next available coaching appointment. Then the care navigators follow up with members via chat within the app to ensure that they were able to find a suitable appointment and that the provider met their expectations. Behavioral health coaches, and then this is just one of the things to call out. This is a separator, and we'll talk about this here a little bit more in further detail, is that these behavioral health coaches are not licensed clinicians. So they're not licensed clinicians, they're not master level service individuals. 70% are masters above. The other 30% are well coached, certified in behavioral health. So if you take a look at the Uprise EAP Care Navigation Pilot Program, where you're currently at right now, you can see that your current program and how it's set up through Uprise Health. You're going to get the addition of a brief well-being check. You're going to get the addition of a personalized care plan. You're going to get the addition of intelligent triage based on assessment, live mental health care navigator, proactive outreach based on your members' risk levels. So the high-risk individuals are going to get an outreach right away. Evidence-based digital courses, which you have right now, coach-guided digital courses, behavioral health coaching, including real-time booking. You have their group sessions. Those are going to be added. Teletherapy, you have that right now. In-person therapy, you have that right now. And then one of the things that they're going to be looking to do, Uprise Health, is real-time booking for teletherapy appointments. And, you know, some of your real disruptors in the market that I'm sure that you guys are familiar with in the mental health space, you know, that's one of their differentiators that they have, is that people can come in through a digital front door, they can connect with the care navigator, then that care navigator can help them in real time book teletherapy appointment or a virtual appointment or an on-person appointment, and the turnaround times for those are usually like 1 to 3 days. So it's really immediate, quick to access and care. So they're going to have that on that roadmap coming forward. And then one of the things that they're also going to be looking at doing is tracking outcomes using the GAD-7 or PHQ-9. So, and those are your assessments in this space, your mental health assessments in this space. And Brad, did you want to add anything additional?
No, I
or-
was just going to
No?
ask what those were. So
Yeah, so
in case
sort of like
others
when you
on the
take a look-
phone were wondering as
Yeah,
well.
when you take a look at, like, you know, your well-being vendors who do a health assessment with people, right? So your mental health vendors, they'll do a GAD-7 PHQ-9 to assess the individuals where they're at. And then what you want that vendor to do is periodically come back and reassess that person for 6 months, 8 months, 12, whatever the cadence is, so you can have a definitive measure if that person is improving as part of their care plan. Right, so any questions on the pilot scheduled to begin at Salem Kaiser in April 2022? No? Okay, so if we want to go on to the next slide. All right, so care navigation pilot reporting and considerations. So these are the suggested reporting metrics to measure effectiveness of the pilot program. And I believe, Tanya, I've already provided these over to Jay at Uprise Health, but if he wants additional copies of this, please let me know. We can share it over to him. But so these were some of the reporting metrics that we would want to take a look at the end of the pilot program. So the engagement utilization monthly, the number of pilot program participants who engaged with a care navigator, right? So we're going to be paying to add this additional service. What are the number of individuals who actually utilized it? What was your speed to care and how did this increase a member's access? And then pilot program participant outcomes along the behavioral health spectrum of care. So your low, medium, and high risk individuals, as they come into this pilot program and they work with Care Navigator and they're assessed if they're low, medium, or high risk. If I'm a high risk person at the end of this pilot program, am I considered medium? If I'm medium, am I considered low? So how do I move along that spectrum? And then, as always, participant satisfaction. And then some things to just be considered. While the Uprise Health EAP pilot program is a step in the right direction, it still does not have the ability for teletherapy with real-time booking. That's going to be coming soon. The Uprise Health EAP pilot program rewarding metrics are currently in development, which we are collaborating with them on. Uprise EAP pilot program network of care navigators and providers is in process of development. So this is a big one for us to keep our eye on. This will be a larger item of concern if OEB decides to offer this solution to the entire population. I think we're all aware that in the mental health space, mental health providers are in great demand right now. So their care navigators providers in a process of development. So let's just keep our eye that they can handle the bandwidth as we continue to offer this pilot program. And then Uprise EAP pilot program care navigators offering has components of a best-in-class program at a reduced price. And why I share that with the OEB members is that, you know, I've helped many groups here in the past 18 to 24 months do EAP RFP solutions for what they call these enhanced reimagined EAP solutions. And while these reimagined enhanced EAP solutions are the Cadillac of EAP, they come with that Cadillac price tag, right? And so they're significantly, in many cases, 4 to 5 times more expensive than your traditional EAPs. So ideally what you'd want is to work with your current provider and, you know, bring them along and have them add these additional features and make sure that they have the access to training, the quality of care, the provider network, and still have this at a competitive price. So go right, I think we have a hand up. Go right ahead.
I know we had discussions about the role of EAP as it relates to behavioral health services. And again, this is just one person's thought, but I don't really view EAP as the primary provider for ongoing mental health treatment. That should be your medical plan. And being that EAP doesn't coordinate with our medical plan and our big push is coordination of care, I think this would detract from the totality of what we're trying to accomplish with coordination.
Okay. Thank you.
Fair comment.
And that's something that we can definitely feedback that we can share with the provider.
Yeah, and JJ, you're right. You know, a lot of these, I mean, there's not a huge number, but the disruptors in the marketplace are really blurring those lines between sort of an EAP and an ongoing, you know, behavioral health therapist provider, where, you know, if you reach the limit of your visits, they're often able to extend the services out using that same therapist, but just billing it as a claim under the medical plan. So that is a distinguishment here. But I think that said, you know, we talked about this a little bit with Tom Siltabo and wanted to share a little bit of his feedback, and he'd probably laugh at me because I probably will misinterpret a lot of his stuff. But his comments were that, you know, an EAP is meant to address, you know, some really critical immediate needs. And a lot of the value in therapy and EAP programs is done in the initial visits, you know, in the first couple months. And, you know, less as the longer someone continues on therapy, the less, you know, value that is often found from that. And so that's kind of a consideration, you know, if we do want to have an enhanced program, which we think a lot of the stuff in here sounds pretty good. If we want to have an enhanced EAP program, but we don't want to pay the often millions and millions and millions of dollars that are associated with some of these really robust solutions. And don't get me wrong, I'm a firm believer in investing in mental health care. Huge believer in that. This is might be a nice way to go in the short term. We're also lucky that it's currently in pilot program, so we would have an opportunity to observe it, you know, look at some outcomes, you know, work with Uprise to say, hey, here's before we go on this, these are the kinds of things we'd like to see. You know, we really want to make sure you can actually show us your performance a little bit on this pilot program. So
thank you.
So while I totally agree with you, yeah, it's a maybe a step in the right direction. So
increasing the access to care and getting people the right care that they need at the right time. So Rose, if we want to go to the next slide, we've already sort of touched on some of these recommendations. So the Uprise Health EAP renewal recommendations: renew current program for October, 1-year term, defer adoption of care navigation for entire OEB population until pilot program has been completed and evaluated. recommend formal procurement process to consider modern EAP behavioral health solutions, review EAP vendors across the market landscape, traditional versus disruptors, identify EAP vendors that utilize best-in-class features, has high engagement across their book of business, drive outcomes at the most competitive price, and provides care across the continuum of mental health needs.
Okay, so what I'm seeing off of this, I think there's only really one action item for the board today, and that's the first one, whether or not to renew the program as the current program for next year. Is that correct? And then the others are just things we do without action. Is that correct?
Yep, that's correct.
Okay, I'll entertain a motion then.
JJ, so moved.
Okay, we have a motion to renew the current program for October for the next plan year.
Suiki Smith, second.
Okay, we have a second. Thank you. And all those in favor of renewing the current EAP program for the next plan year signify by saying aye.
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 Okay. Anybody with a nay? Okay, the ayes have it. We're going to renew the current EAP program for the next plan year, and then we'll take a look at the pilot program and other procurement processes later.
Okay, great. Awesome, thank you. And we are going to go on to the next portion of the presentation. And Robert, I don't know if there's a scheduled break or you want us to just continue pushing along. I'm good either way. You let me know what works for the team.
Okay, on the agenda, we have it scheduled for after this, but I would like to do a small break and welcome Michelle to the OEBB board. I don't see her picture on my screen right now. So Michelle, if you don't mind, I told Enrique this, if we were live, then we'd be able to introduce ourselves and not put you on the spot. But I hope you don't mind just introducing yourself a little bit and just tell us a little bit about yourself so that we can welcome you into our OEBB family.
Sure, thank you. My name is Michelle Dewberry, and I work for Portland Community College. I am a grant writer, and I've been there for about 11 years now, and also serve as the Vice President for Communications for the Federation of Faculty and Academic Professionals at PCC. So I've been on 2 contract negotiation teams over the past 4 years, and really got interested in learning more about how these health insurance options sort of filter down to members of our local. Because of a family tragedy in 2010, when my son was killed by a careless driver, and we just had a secondary trauma of navigating what I thought was good health insurance after that happened. And so in 2019, I initiated and passed health insurance legislation called the Made Whole Doctrine in the Oregon legislature that prevents health insurance companies from taking pain and suffering settlements from car crash victims. And so that was, like I said, that was 2019. And now I'm just here really hoping to make the landscape easier and more navigable for people who are in my union, who are public employees in general, who might actually have to use the healthcare system. So it's pretty tough. So that's a little bit about me. Happy to be here.
Thank you, Michelle, and thank you for jumping in right when we're starting to make decisions and being a good sport about it. All right, so yes, Matt, we can continue on with the renewal options for our medical plans.
And
okay.
This is, yep.
Go ahead, Jesse. I was just going to say at this time, I'm going to turn it over to Jesse Knight, who's my colleague, and he's going to take us through the
I'll be doing my best to cover for Jenny here.
Jenny Marks.
Okay.
But I think I've got Matt and
Almost
Brad to
impossible.
help me out. Yeah, Brad can help me out a bit too. So, so this is a continuation of last month's board meeting where we went through the preliminary renewals from the carriers. This is sort of a mini update focused on the medical renewals before we, in a month, come back together and look at the final updated renewal positions for the vendors. We do have some good news. I assume some people looked ahead as far as an update on the MOTA renewal, but we'll go ahead and take you through it step by step. And Rose, can you take us to, yeah, thank you. Go ahead and go on to the. So this is our roll-up summary. This is updated just with one item. It's MOTA's new round 2 renewal position. And I'm looking at last month's on my other screen here, and MOTA had come in with an initial renewal of 4.4%, and their round 2 slightly revised renewal has come down to 3.2%. So that's great, and we'll go through that piece by piece momentarily. And then over on the far right, the other highlighted item that we care quite a bit about, the 3.3%, that's updated for MOTA's medical there, and that last month was with the initial preliminary renewals was 4.1%, so above the 3.4% target. So now we're just a little bit below that target. And again, we'll in a month we'll be coming back together and actually providing updated kind of final renewals positions from across the board because we don't have those just yet. So any questions on the roll up? Hopefully there's some thumbs up.
From a cadence perspective, I think it's worth noting that we typically, so MOTA provided an intermediary renewal update that we often don't receive. So a lot of good partnership there after some discussions and some back and forth dialogue. Typically we get the final renewals for all of the vendors a little bit later, and we would present those in the next month's board meeting. So a little bit of early good news.
Yep. Okay, Rose, go to the. And this is just a sort of recap of the rate stabilization reserves. This was in last month's deck materials as well. It's just kind of summarizing side by side. MOTA and Kaiser both have healthy reserves. That was mentioned in the earlier section around these being available for buying down renewals, paying for things like special new wellness programs, and so forth. So that's a consideration. And we did talk last month about what it would take to buy down the renewals to the 3.4%. In the case of MOTA, because they're now below 3.4%, we don't have an update to that number in that case because we're already there. So that's just a quick recap there. Go forward, I think 2 slides. Yeah. So like I said, Kaiser did not provide that kind of interim round 2 update. So they're still at a 6% increase. We've shared feedback, given them the opportunity to kind of relook at some things in their renewal assumptions, and then of course they'll include some more plan experience in time for what they share. I think around the middle of this month, and then we'll put that together with the materials for the April board meeting to share with you. So one of the things that we talked about last time is plan change options. And this is meant to we have a little bit of an update in terms of the pharmacy copayment on generics. Last month we just basically had this bullet here. We do have a slide that follows that we'll look at just to illustrate the change. It's fairly simple, and it's basically reducing the renewal by 0.8%. And hang on to that number because we'll get to that on the next slide as I show you the copays design for that. And then this is just like we said, the same as before, the rate stabilization funds that would be needed to buy down the renewal, to reduce the renewal from the current 6% to 3.4%. It's about 5 million. I think it was about 15 million on the prior slide. So a good chunk of that reserve funding would need to be used up, about a third, to buy down the renewal. So of course we're hopeful that we'll get a more favorable renewal with the update that Kaiser will be providing a little later this month. So
Yeah,
next
and
slide.
just a final comment on that before we move on. That large adjustment from a 6% down to a 3.4%, as we've shared with the board in the past, and for the new board members, we typically don't recommend making adjustments that large because it's kind of the old, hey, you can have it today, but you have to pay the piper tomorrow. And having those really large decreases will result in a potentially leveraged increase the following year. So it can make it really challenging. If you take it all today, it can make it really hard to meet the goal tomorrow.
Thanks, Brad.
Mhm.
Okay, I think the next slide is our plan design. Quick summary. Great. So you'll see the purple box there is meant to highlight, these are the Kaiser plans, 1, 2A, and 2B. The pharmacy copays, vary by tier. The generic tier being $5. The proposal is to double that to $10, and that's, as mentioned on the earlier slide, that would be worth a 0.8% rate decrease. That would also, we didn't box it out, but we'd expect that to correspondingly apply to the mail, the 90-day supply down below, the $10 doubling to 20. So that's, are there any questions on that one? Because that's, I think we talked about that one a month ago. Conceptually, we didn't share the plan design, although it's a fairly simple change to the design.
So I do have just a clarification question. The prior slide said it reduces the renewal by 0.8%. Is that to get it to 6, or is that taking it from 6 to 5.2?
The latter. Yeah, it would take it to 5.2.
All right.
Okay.
We've just built to make sure.
I should also, especially with the new board members, I should note that the preliminary renewal increases on that earlier slide that rolled up only include basically mandated design changes that are required by the state or federal government, or book of business changes that the carrier is pushing through. So that's sort of our starting point. And then this is an example of an optional change. And then we have another one for MOTA a little later that we'll talk through as far as kind of at your discretion changes that might in this case help the renewal position. With the MOTA one, it's actually a change that would increase the renewal as far as an optional change a little later.
So going back to slide 4 then, so if we kept Kaiser at 6% and everything else remains, everything on that slide remains the same, then we're already under the 3.4 without any modifications.
Correct.
Right?
Yes.
Okay. Thanks.
I suppose, and Brad, I probably should be careful here. The updated renewals don't necessarily always go down. Brad, I would think that might be the case. They add a month or two more of experience to the underwriting, and they could go either direction.
That's right. We always have our finger crossed, and generally, the trade-off is you add a couple more months of experience and you use a couple less months of expected trend. And sometimes our expected trends tend to have a little conservatism in there, and so when we replace trend with experience, we often are at least neutral or go down a little bit. But there's certainly the potential for an increase.
Okay.
Yeah, good caveat there, Jesse. Thank you.
Thanks. Okay, so that's Kaiser. I think we have MOTA next. Yep. So this is the round 2 update from MODA that went from something like 4.4% down to 3.15. 3.2 was our roll-up slide rounds to tenths of a percent. Here we're showing hundredths of a percent as we have in our renewal reporting template. So one little distinction here, because I don't think we talked about this earlier, we talked about it last month, is just that the 3.15% is the number we focus on ignoring changes to, before any consideration for changes to federal taxes and fees. And that's just around the 3.4% target rules. And so in the past, that adjustment factor there has been quite a bit larger. It's almost nearly nothing in this case. But we are focused on the 3.15% in terms of getting to that 3.4% target. So as far as updates with the round 2, no change to trend assumptions. They did remove, MODA did remove the additional COVID-19 margin, which I believe was 1/4%. So that helped bring the renewal down just a little bit. General margin, 0.5% now, reduced from 1%. That's even more helpful. And then, like we mentioned before, they did include more experience, another 2 months of experience. It was through September with the initial renewal that they provided. So now it's through November, and we think that typically, I think it includes December. At least looking at what happened a year ago, the April report we'll have for you will include an additional month of December we'd expect to see. And then no change to administrative fees. The 3% increase is still there in their renewal. And then the last time we spent a little more time talking through the state and federal mandated benefit changes. Those are in the very, very end of this deck. It's an incremental increase of 0.8%. That's built in already to the 3.15% reported here. So those are the ones you can't avoid. Those are going to happen. So we've included.
And so in general, very good renewal results. If we think about it from a before the state mandated changes, we're kind of down into that 2% range. So very, very good result.
Yep. Okay, so the next slide is going to look at a plan change option. This is, I should say, options. What we just talked about was the mandated stuff, but put that out of your head. This is optional proposed plan changes, and we went through just about all of these last meeting, and we've tried to document the preliminary decision at last month's meeting. These didn't get voted on. These are simply what we heard from the board members as far as which way people were leaning. And I will say that I think Dr. Siltebo certainly provided some guidance on these, but again, these are not, that's why we've noted them as preliminary. But I'll just recap them fairly quickly. The prostate screenings, that's a state mandate that is going to be sunset. The reaction from the board a month ago was basically not to change it, even though you're allowed to. You could change the benefit if you'd like to, but the desire was to most likely leave it the way it is. And then the diabetes maternity program is another item that's going to be sunset. There's a little bit of savings, negative rate impact on that one. That one was viewed more of favorably, and so the idea of removing that benefit level that had been a mandate from your program was accepted or viewed more favorably. Same for the diabetes services, the testing supplies and continuous glucose meters. That was moving from the medical coverage, I should say, removing medical coverage and only having it covered under the pharmacy benefit, whereas that's a more standard coverage, and there are savings, more savings on the pharmacy side than the medical side. So, and thus that drives a 0.5% savings to the plan. That was also viewed favorably. And then the site of care expansion, this is around oncology, therapeutic oncology medications would be managed, steered to most appropriate and economically favorable site of care, and that was something that's been discussed as a long-term program care management mechanism that does drive more significant savings than the other items, actually, about 0.1% savings, and something that MODA has been working on for and kind of staged over the years to implement that. So those 3 items were viewed favorably when we talked a month ago. The other one, which we're going to dive into more deeply today, is the removal of the maximum cost share feature provisions from plans 1 through 5, and we actually have a couple of slides on that one, so we're going to get to that in a second. As you'll see, this is pretty material. It has a 0.7% cost increase impact to the renewal, and this one was a lot of questions last month about this one, so we're gonna spend a little time on that one. So put a pin in that one. We'll get back to it in a second. And then we have a whole section on the behavioral health program that MODA is launching. And so we won't go through that here. I should probably caveat the rate impact on that one. Probably better to say TBD, because there are components of it that we're still waiting on final pricing details from MODA for, and we'll get to that in the next section. But again, there was certainly no decision made around that because we didn't have details to share at last month's meeting. So we're gonna spend some time on that today. So in summary, the 3 items checked as preliminary accept, kind of favorable viewed, it adds up to about 0.17% decrease, and that brings the renewal roughly down from the 3.15 to around 3%, just kind of using rough numbers to give you a sense. It's not particularly material, but it is helpful. And then if you were to make the change to the maximum cost share, removal of the maximum cost share, that really more than wipes out any of the savings from the others. So that's why we're going to spend some time today talking about that plan maximum cost share removal option. Any questions on these before we get into the maximum cost share piece? Nope. Okay. Rose, can you take us to 12? Yeah, 12. Thank you. Okay, so last month we just talked conceptually about it. Here is the actual plan designs for plans 1 through 5 that would be impacted by this. You have a somewhat unique set of provisions here around kind of maximum cost share and out-of-pocket. I'll first talk about the out-of-pocket maximum, which is really focused on, or really includes medical deductible, medical co-payments, and medical co-insurance. It does not include the additional cost tier co-payments. So and that amount is, it's obviously a lower amount than the second item, which is your maximum cost share, which I believe was added a few years ago to address the Affordable Care Act, healthcare reform, individual maximum that applies to just about all private plans out there. And so that's the 7,900 that applies across all those plan designs. The proposal was put out there to MODA to, if we just got rid of that maximum cost share, the way it's designed today, and I think the way to probably think of it is you would still need to have that kind of all-in out-of-pocket maximum amount where everything would count towards a number that meets the Affordable Care Act caps. And so I think the next slide is meant to explain the member impact of basically reducing that maximum cost share level down to the out-of-pocket maximum level. So instead of someone having their cost sharing stop at 7,900, it would stop at 2,850. So it's obviously very impactful to Plan 1. Those in Plan 1, a lot less impactful to someone in Plan 5, just because the deltas, the differences between the two values. So we're going to talk about that on the next slide too. I will say that the maximum cost share, just to highlight what is included in that one and not in the out-of-pocket maximum, is, like I said, the additional cost here co-payments, which are really things around imaging and certain types of surgery, where there is quite a big co-payment in the case of the surgeries. I think it's about $500 that does accrue to that maximum cost share amount, but does not count towards the out-of-pocket maximum, the smaller amount today. Right.
And
so
if this all sounds really confusing to everybody, it kind of is, which is one of the reasons that I think we've, just from a member experience perspective, I think is one of the reasons that we're looking at saying, hey, how can we take some of this complexity out of the plan? It's all great in theory, and when we look at the history and how it formed and came about, it all makes sense, but it's really confusing, particularly for members who aren't, don't have the benefit of walking through the history and, having somebody really sit down and explain it all to them. And so, it just said really easily, essentially what this would do, it would take all of your pharmacy copays and these preference sensitive treatment copays, and it would just stick them under the lower number there, that what's traditionally, and commonly called the out-of-pocket maximum. And so it's a little bit of a cost, it's a little bit of gain for folks, particularly folks that use a lot of pharmacy services. But that's one thing, it's a large simplification. And I think we really just went and said, asked MOTA to say, hey, if we did this big simplification, we know there's going to be some winners on this. What would the cost impact be? And that's where we got that 0.7. So.
Okay, so Brad, that makes a little bit more sense, because I was thinking, this was going to actually be a savings, but just clarifying for me, really, we're talking about replacing that out-of-pocket maximum. Never mind. Yep. It's not that, but
it's confusing, right?
It's adding pharmacy to the out-of-pocket maximum and then just getting rid of the maximum cost share.
Exactly.
Is that it?
That's
okay.
the really big piece. Not
That's
that many people are using these preference sensitive copays. We like the preference sensitive copays because, if you go in and get an MRI or, have joint surgery and stuff, those things are little gatekeepers to make people say, should I stop and think for a minute? But at the end of the day, this is impacting a lot of people, and it's really confusing. People see this out-of-pocket maximum, the first number, they think they've hit it, and then they keep getting charged, when they use their pharmacy benefits or different things. So uncommon, it's a little bit of an uncommon structure to have. And, and maybe this is a good year, maybe this is not a good year, depending on, where we end up from a cost perspective and a target perspective, but really wanted to bring it to the board to, one, give it just a reminder that you've got this feature out there that's a little bit confusing, and then bring up, what would it cost to solve this, as we try and make this program more and more attractive for people and entities to elect.
And the next slide does talk about member impact a bit more. So maybe we want to look at that. And it's favorable, because it costs the plan more money, it's going to help quite a few people. But as Brad said, it heavily helps those with pharmacy, significant pharmacy expenses. It's basically, well, I'll talk through these here. So there's 250 members who actually met that maximum cost share, the 7,900, in the prior plan year. So those are kind of the people who'd be really, really helped out by this change. And then kind of in the middle are the people that are in the corridor of between that medical out-of-pocket maximum and the maximum cost share. So there's 4,000, roughly 4,000 members who have exceeded the medical out-of-pocket maximum, that lower amount, and did not quite reach the additional cost share, or sorry, the maximum cost share level. So they're in that corridor, and they averaged, those 4,000 averaged about $800. So they would be, if you did move it back down to the medical out-of-pocket maximum level and kind of threw everything into that bucket going forward, those people would on average save $800. So that sounds like a lot of people. It's not. That's not a lot of people when you look at your whole membership. And like we said, it's people who are, it's heavily pharmacy. It's, you know, it's not really the people with the, not many people with the additional cost tier copays, because those frankly aren't typically recurring. You know, it's a surgery, and you're not going to have 3 hip surgeries in a year. Hopefully, you're gonna have that one surgery and pay your copay, and that's not really gonna tip the scales in terms of working you towards that maximum cost share. So there's this helps some people, but it definitely skews to those who have the significant pharmacy costs. And we do want, you know, we do want people to look at options around what drugs they're using, and if there are new and less expensive drugs that they can switch to. So there's that consideration too. So let's see. So then proposal to eliminate maximum cost share. Yeah. So basically that's the verbal, trying to explain the what we just talked through the prior slide. We felt it was absolutely necessary to have to show you the two side by side, because I'll be honest, I had to look through 3 different versions of plan summaries to make sure I understood what we were talking about, including the SBC, which is, you know, that government mandated form that's meant to be in English. And I can tell you, that wasn't very useful. I need to look at footnotes on your more detailed plan summaries to really understand it. So let's talk about the impact to the renewal, just financials of this. It's a 0.7% increase. And that, like I said before, it does vary by plan. So plan 1, which is the most generous, the impact, of course, to that one is 1.5%. So heavily skewed to people in that plan. They've come out quite a bit ahead in terms of making this change. And then plan 5, where there was a very small difference between the medical out-of-pocket maximum and the maximum cost share, only a 0.04% impact. So almost nothing. And the reason being is the people who, you know, people often have choices in these plans. The people who have these, you know, they look at their plan design, they're going to pick the plan that's most favorable to them. So it's going to skew a little bit that way. So we don't want to say it's going to apply kind of across the board to everyone equally. It is skewed to certain plans.
So Jesse, this is the cost impact and not the benefit impact, right?
Yeah, the rate. Yep, renewal rate, okay. Cost impact. Yep.
Okay.
Yeah. So overall, spread across all your plans, about 0.7%, which is about $4 million, give or take, you know, a little bit. And, you know, if the board's interested in this, you know, that's something that that we can take back and hone and refine a little bit further. There are ways that we could mitigate that if there's interest in pursuing this right now. But it's also something that we could review, the board could review over the course of the year and say, hey, you know, if I bump everybody's out-of-pocket max up a little bit, could I make that 4 million go away? You know, that kind of thing. So there's other ways that you could, as the board, you could mitigate that cost impact. You know, or if we have some really favorable results as we come in, there's, you know, and if there's room to make that change. But, you know, as it sits, we'd probably, you know, I know there was interest from an affordability perspective, and, you know, some folks had made some comments and questions, which is why this was brought up. But I think in general, unless there's a lot of interest for it right now. You know, we would recommend maybe holding off on that until there's a little more room, you know, from a composite renewal perspective. You know, as Jesse showed us, we're just really close. We're sitting at 3.3, and adding this 0.7 to the rates, you know, effectively having this benefit improvement would cause us to go over that composite renewal increase.
And I don't know, Brad, off the top of your head, if you know how long the medical out-of-pocket maximums have been at the levels they're at. Like
yeah, that's a great question, Jesse. For some of the newer board members, you know, those items have occasionally been increased, but not very often. So I think there's probably a little bit of room to do some more looking at that too. That big number, that $7,900 number, that, you know, that traditionally has been indexed every year as the federal government puts out their out-of-pocket maximum limitations. So that has traditionally moved up. Last year, the board decided not to implement that change, and part of that was due to affordability concerns. You know, those numbers were a little bigger than we were seeing in our benchmarking for education sector.
Okay. We have a question from Bill.
Mm-hmm.
Hi, thanks for this. I know we were talking about this over several months, actually, especially at CAO, because we're kind of advocating the position of our lower paid non-licensed community, you know, that are struggling. They will typically not have a choice between all these plans because they'll have to take the lowest cost plan due to their income levels. And they are basically on the edge of one-time medical expense that will put them into bankruptcy. And that was the whole, from my point of view, that was the gist of what we were talking about. And my question on this is, you know, we're talking about bringing this in, and this is what Tom and I were debating on the side, you know, on how to make this risk level go down for our lower income members. Is there an ability to walk towards this over the next couple years or whatever? Or is this a all or nothing deal?
Yeah, that's a really good question. You can always phase changes in over 2 or 3 years if there's a big impact. That's not uncommon to do. But I think to address the main question, right now, those lowest cost plans are, you know, your plans 5, 6, 7, you know, those are your lower premium cost plans. And if folks are already electing those lower cost premium plans, this is not going to help them because, as we saw, your largest impacts are on your richer plan designs, which would be the 1, 2, 3.
Yeah, not just per monthly cost, but it's also how much cash you have on hand that you are willing to put out at risk. Mm-hmm. Right? It's a balance there. Yeah. It's not just the per month cost when you're talking low income.
That's a good
members,
point.
Right?
Yeah. If you
yeah.
Yeah, if you did have low income members that are willing to put out that higher monthly premium cost, that would help them a lot because they would their variable cost from an out of pocket perspective could go down significantly.
Yeah, I'll leave it at that. Thanks.
Yeah. Good, very good comment. Thank you.
Brad, this is Ali. I was just going to raise the point that depending on Kaiser's data refresh going into next month and where that leaves the board in relation to the composite rate may inform this decision, or at least the approach to it.
Absolutely.
It'll be down.
Fingers.
Okay, any other questions or comments?
I see one more hand up.
Sorry.
Michelle and then Susan. Sorry about that.
I just, you know, I would be in favor of eliminating the maximum cost share just from the point of view of a member trying to understand their benefits. It really feels like a bait and switch when you think you have a certain benefit and then you have a catastrophic medical event or even just a routine expensive medical event. And you end up being on the hook for a lot of money despite paying, thousands of dollars in premiums every month. It's a horrible situation to be in. And my question is, if we keep that, is there a way to make it clearer to members to communicate in the materials what it is? Because I have stared at that line in my own benefits and not understood what it meant. And I think some of the language in the materials that members get is just confusing, and it's hard to even know who to ask to explain it.
And the numerical examples would be very complicated, frankly. I think that, and I'm just going to speak off the cuff here, most of that impact is probably on the pharmacy side, and a way that you could simplify it and we would want to talk to MODA about this too, because there's other implications, but a way you could simplify it a fair bit would be to remove everything other than pharmacy out of pocket from that. And then you could label that sort of a medical out of pocket maximum and a pharmacy out of pocket maximum. And that would probably be a little bit more easy to understand from just a kind of a separation of those things, rather than have part of the alternative cost tier and other little things that might go into there.
Which is how Kaiser actually has theirs. They have a medical out-of-pocket maximum and a pharmacy out-of-pocket maximum on the earlier slide up above.
And
Okay.
I don't.
Oh,
good. Sorry.
I was just going to go on to Susan, but if you have something else, please do.
No, very good.
Okay, Susan?
I was actually going to say something. Thank you. I was actually going to say something similar about the maximum out of pocket, doing them separately if we did go this route. But for the 23,000 members that my organization represents, they're primarily in the 5, 6, and 7. So this cost would far outweigh any benefit that they would likely see from it.
I think we would. I guess maybe we want to confirm this with MODA. I think the rate impact would be applied by plan, as opposed to the 0.7% being applied across all the plans.
That's correct.
I think that would, it's almost no impact, 0.04 on Plan 5, and there's no impact to the rates on 6 and 7, which are qualified high deductible plans, which have entirely different and probably much simpler and cleaner, true out-of-pocket maximum levels.
So Jesse, if we're going to delay this until next month to see how Kaiser shakes out, could you also come up with what it would look like if we raise the out-of-pocket maximums to make this either mitigated or net zero?
Yep.
Just for us to look at.
Okay. No problem. Okay. Anything else? This is, we can reconnect on this next month, and I think we're ready to switch gears to the MODA behavioral health program, which is the next section.
Yep, sounds good, Jesse. So Rose, can you push awesome. Thank you so much, Rose. So as we switch gears here and we begin discussion of the behavioral health solution that is being offered by MODA Health, we want to just sort of set the stage and go back to the board members here and recap sort of the current state of mental health behavioral health among the OEB population and just share some data analytics with you just to sort of as a refresher for everyone. So if we take a look at the OEB behavioral health current state assessment, this is clinical risk and engagement. You can see during the top left there, during the 2019-2020 plan year, mental health represented 7% of the total medical RX spend. So that was about $45.9 million, and that was up for 6% for the prior year. And then if we look right to the right there for the 2019-2020 plan year for the per member per month medical costs, you can see where mental health, substance abuse ranks in terms of your other top 5 drivers of healthcare costs. So number 1 was MSK, number 2 was cancer, then you can see mental health there, then you have pregnancy and infections. 18%, if we go to the right, 18% increase in behavioral health spend per member per month over the last 2 years. And then if we circle down to the left, depression and anxiety are high in prevalence and cost and increased 9% and 7% from the 2018-2019 plan year. So we can see there, if we specifically look at depression and anxiety, then members accessing behavioral health. So you can see that is increased just a little bit from 2019 to 2020, but still right around 19%. And then 20% of total allowed relationship. You can see employee, child, and spouse who's accessing it. Member access has been stable, but employee access has been increasing, especially for substance abuse. And that's something for us to keep in mind. And just in regards, when we talk about behavioral health, mental health, I mean, I think we all know right now, due to the current pandemic and the current state and climate of the world that we're in right now, it's never been more of a important issue to make sure that you have proper mental health solutions that are available for your faculty and staff. You know, I'm here in California, and before I came to WTW, I worked with public schools exclusively for about 8 years here in the state of California with their faculty and staff designing employee wellness programs, and mental health was always our #1 initiative. And in the state of California, and I can't speak to what they are in Oregon, but the burnout rate for teachers, new teachers, is about 55% in the first 2 years. It's something just extraordinary. And so they're just dealing with things now today that, you know, and historically they've never had to deal with just in terms of technology and access. So making sure that we have best in class mental health solutions available to them are more important than ever. So continuing on to the next slide. All right, awesome. So OEB's current mental health resources, and you know, there's an impressive array of mental health solutions that are available today through the OEB medical plan. And what we did, and you may have seen this slide previously, is we broke those up, and we've talked a couple times today when we looked at the EAP program, and that was providing mental health solutions across the entire spectrum of care. So when we take a look from healthy to severe, do we have solutions that are out there for everyone, regardless of where they are on that continuum of care? And so we have, you know, healthy, stress and resilience, sleep, work-life balance, financial planning. These would be like your day-to-day things that people are dealing with. And then as you go to the right, the issues get more severe: anxiety, depression, OCD, family issues, substance abuse. And then we get to the severe, where you're suicidal, acute mental illness, detoxification. So your severe substance abuse, mental health issues. And then you can see here to the left, to the right, you can see the self-directed solutions that individuals have in place, and you can see through the carriers. I think both of your carriers do a really great job in providing mental health solutions, not only theirs, but then also their third-party vendors that they have now added in addition as part of their plan. You can see OEB has MODA has Miru Health, and then Kaiser has the Calm app, which are two really prominent providers in the mental health space here in resiliency. And you can see the additional ones there that are available for Strength and Headspace and Will and WebMD. And then you also have Uprise Health, which is your EAP provider. And then as we move to the right, you can see we go from self-care to counseling and therapy, RX and psychiatry. You can see down below, and that's when you start getting into the Cirrus MD, the Ginger, those solutions that are available. And then you have your outpatient and inpatient treatment, where there you're dealing with the carriers. And so what we are looking at today, and we are looking at MODA's behavioral health solution that they have provided for us to review, that they're offered up. And so what we want to do before we take a look at that solution is take a look at what best-in-class behavioral health programs offer the following features. And some of these you should be familiar with because we discussed some of these when we looked at the EAP provider. So care along the entire continuum, which we discussed, common digital front door for EAP and all carrier mental health solutions. So that one consolidated front door access that people can get to find all of their solutions. Care navigation to appropriate resource, self-directed digital coaching, talk therapy, and intensive treatment. Quick access to treatment. You know, that's the big thing with EAP providers that are your traditionals. A lot of them, it's a week to 1 to 3 weeks before you can get in there and get anybody care. And the amount of people that will continue and see that, that's where you see that utilization drop off. So the quicker that we can get them access to care, the better chances are that we can get them headed in the right direction. The ability to select a provider by language, race, ethnicity, and specialty. So that's your DEI component there. You know, are they able to LGBTQ, providers of color? Did they have a wide range of access to those individuals? High quality providers, and then data driven and results based. So pretty straightforward slide of what you have there. So Rose, if you want to go on to the next slide, please.
Matt, I think Michelle might have a question or a comment.
Oh, sure. Go right ahead. Sorry, Michelle.
I don't have a question. I don't know if my hand was raised by mistake.
Yeah, I think, Michelle, you got to take your hand down once you put
Got
it
it.
up.
Okay.
Yeah, no worries. No worries. Teams is, yeah, no worries at all. Did anybody else have a question before we go on to slide 17? No? Okay. So OEB behavioral health, your current state approach. And so what this starts is that let's put ourselves in the position of I'm an OEB member, I'm a faculty and staff member, I'm stressed out at work, I'm having issues, the kids are driving me crazy, you know, I'm having financial worries, you know, I'm just having a lot of stuff. And I decide that I want to contact and get help through the OEB program. What does my process look like? What does my experience look like? So right now, members can access care through the mobile app or call the OEB dedicated EAP phone line. Members have access to 4 coaching sessions and 6 counseling sessions through Uprise Health. Those can be in-person, video, or telephonic. This is risk level low, medium, high, and this is determined by the initial assessment that they are given. The expected wait time currently for individuals to get in is 1 to 3 weeks. So that's what we talked about, the little lag time with care. And, you know, we're just having that phone line to that mobile app. So the carrier health behavioral health solution. So then they're exhausted those, and then they are warm transferred from the EAP to the medical carrier, or member can access care via medical plan. So they can either access the EAP or go straight to access care via the medical plan. Members also have access to self-directed behavioral health solutions through carriers. So we talked about these earlier, the Calm, the Headspace, the Miru. Navigation experience differs based on medical plan. So MODA versus Kaiser. So issues with the current state as it is today. No common care navigation for all available resources solutions. So this could be determined as being disjointed. Limited knowledge of available resources. And, you know, I think we've spoken with individuals, and and this isn't OEB specific, but I have a lot of that have Kaiser, and they're not aware that they have Calm. They're not aware that they have My Strength and these different solutions that are available to them. So a lot of times people aren't aware of these different solutions that are available. Most OEB members are using the medical plan to access care, which is more costly than EAP. Varied access to care, varied wait times, limited to no reporting on access, care improvement, or member satisfaction. So any questions on our current state before we go to the next slide? Nope. Okay, so Rose, if you want to go to the next slide. And oh, there we are. Awesome. Thank you, Rose. So MODA's proposed coordinated care for behavioral health program. So this is an optional program change. MODA's new behavioral health program is designed to address the following challenges with the current state: increase access to mental health care providers, improved outcomes reporting, align with coordinated care initiatives and goals. And how they are going to reach these goals and these initiatives is MODA's condition care management for behavioral health program has 4 primary components. So we're going to have a MODA 360 champion, a care navigator specifically for members with behavioral health needs. We're going to have access to additional behavioral health providers via contracted third-party networks. We're going to have a supporting infrastructure, screening support tool, and outcomes management system, and then value-based payments to behavioral health providers. Bonuses for providers which are tied to a total cost of care target. So I think
Sure.
I saw, oh, Enrique, go right ahead, buddy.
Yes, thank you. So I guess I have a question on the third party piece. I feel that for what I've been listening today and some of the previous articles from the previous meetings that I've read, there's a lot of third party intervention or collaboration or business with MODA and Kaiser. And maybe my assumption is wrong, but I was wondering, is this because MODA and Kaiser don't have the capacity, or is this more of a cost saving measure? Or I'm just really concerned that we're looking into third party programs, and the members like myself, proud Kaiser member, got my card here. We're not receiving the services directly from the institution. We pay, we put our health, it's just the optics. When I go to Kaiser, I feel okay. It's a Kaiser patient, somebody from Kaiser who has accountability. There is a high quality doctors. There's a system in place for me. And going to third party, I just feel like we're lowering down sort of the quality of the healthcare system and just cost savings. So I was wondering if you can clarify that for me. I'm new. I'm not trying to be here like a hardcore socialist or have a political agenda. I just want to make sure I just want to know. Thank you.
Not at all, Enrique. And Erica, I saw you come off come on the video. So why don't I'll take a high level and then you can fill up the blanks. And that is a great question, Enrique.
Yep.
And Enrique, to answer your question, I think it's a little bit of both. If we think back to the diabetes prevention program, and we had Sofari from Kaiser, she said, hey, we've partnered with Omada Health because Omada has these virtual solutions that are part of their program. So they're leveraging this technology, this virtual solution that helps them give more variety to their individuals who may not be able to come on site and give these services, right? And then when you take a look at this mental health offering, this behavioral health offering, and I'll let Erica speak to this a little bit more, but we see some of your carriers partner with these third-party providers because they have established nationwide networks of mental health providers that then expand the carrier's capacity to provide service. And so what they're doing is they're signing these relationships with these individuals, and that gives them a bigger breadth and depth that they can provide service. And then also one of the things that I'll just share is that in this health management space, in this healthcare space, it is so rapidly evolving with new technology and new trends and new things that these third-party vendors that come up with in these niche markets, right? Like if you take a look at the Calm app, this resiliency app, I mean, that resiliency app just exploded onto the market a couple of years ago. One of the best app on the Google Play Store and the App Store like 2 or 3 years in a row. And so they'll take a look at some of these solutions that a lot of their people are already probably engaging with, and they'll form a partnership with them because then this person can get reduced cost or reduced, access subscriptions to that solution through their carrier and help ties them into that. So that would be, and Erica and Sofari, I'll let you sort of add any additional comments to this question.
Yeah, so Enrique, that's a really great question. And I think that you're starting to see a lot of these more digital point solutions coming up because there's a lot of new ones coming out in the market right now. And they can provide a lot of opportunity to provide more efficient care for our members. A lot of times that these point solutions offer niche services, and I'm going to switch it over to Dan here in a minute to talk about how that what that means specifically for our behavioral health program that we're proposing. But one of the things that you commented on, and I think that it's very important, is that it is still being managed by the health plan. And so with MODA 360, that's one of the important things about MODA 360, because we don't want to just have all of these different point solutions and bring them in and not have any coordination with our health plan and with our providers. So the Moda 360 platform is really aimed at identifying which members are a good fit for the point solutions that we're offering, ensuring that we're getting engagement in those point solutions for the right members, and then making sure that we're keeping them integrated with their PCPs as well. With the behavioral health point solutions that we're proposing, one of the things that they're going to do, and Dan can tell you about, is that it expands access to providers. So as we know right now with behavioral health, there's a large demand for behavioral health providers, and we're seeing that a lot of people are struggling to get into appointments. And I think that this is seen more in areas such as Eastern Oregon or more rural areas of our state. And then when you talk about members trying to find a provider that fits their needs, so whether or not that's a provider who specializes in LGBTQ plus, or speaks a certain language or has a certain cultural background, that can be harder to find when you are in a more rural area. So when you start bringing in point solutions that expand access to different providers, you're also expanding access to those types of providers that the member may be looking for. So Dan, did you have anything else to add about the behavioral health point solutions?
I think, Erica, you and Matt both got it exactly right. So a lot of these point solutions have a national scope, and so they're able to put together the technology and the infrastructure and the personnel to provide very specific and targeted services. And keep in mind also that MODA as a PPO plan, we aren't a provider. And so we're contracting with providers to actually provide the services regardless. And some of these point solutions end up as just as providers in our network. But then we want to have the ability to really sort of curate that ecosystem of providers that are available. So if somebody needs a particular form of eating disorder treatment, one of those point solutions, that's the thing they do. And they've got the psychiatrist and the family peer support specialist and the nutritionist and the whole package right there ready to go with this evidence-based program that, wouldn't otherwise be available. Or somebody with obsessive compulsive disorder, there's a program that's what they do, and they do it better than anybody else. And so we're able to get people really to the most appropriate, effective treatment for them right away.
So I just want to thank for, clarifying my question, a long question, but I just hope that within this board and all of you directors and leaders in the healthcare provider industry, we continue to have the options and the access to in-person healthcare. I know that telehealth is a popular program, just like hybrid models and, online classes for students. It works for some, not for everybody. And I do want to make sure we keep that in mind, that not everybody's a telehealth participant or a fan. I want to go see a doctor, want to touch my chest, hear my heart, and whatever the case may be. So I hope we continue to just have that as an option, continue to advocate for that. And I'm happy to hear that this benefits our rural communities, Klamath, Pendleton, all the parts of the state. But I think it's a delicate balance, and I hate to see us being the tip of the spear when we promoting telehealth. And I see a lot of sort of like issues with that too. Not everybody in the community has access to a Wi-Fi that line. We all know that's an infrastructure problem. We can't solve that problem as a board, but I think we can recognize that there's some limitations to that. So I appreciate that. Thank you.
And so Fari, I don't know if you wanted to add anything before we continued on to that question.
Yeah, thank you, Matt. And thank you, Enrique, for the question. And also thank you for being a Kaiser Permanente member. To your point about point solutions, yes, KP does use point solutions when we find that there is a gap in our care delivery. So we do, for the behavioral health component, we do have point solution options available that is in addition to the self-referred benefit for the Calm and My Strength applications. We also have prescription or prescribed point solutions for our members. So using other point solution vendors to kind of, again, to help support that gap. With respect to your comments about virtual care and just making sure that, we have access available to to individuals who have different needs. We definitely take that to heart, and we absolutely, when we started the pandemic, of course, a lot of visits went to virtual, but we're finding that there is a bigger need for people to be seen in person, and I think that there's been kind of a shift to that in-person appointments lately. Dr. B, did you have comments to
No,
add?
I think the issues have been covered really well. I would just say that really important of that integration back with someone's routine care when point solutions are used. So it's really how they're deployed. I mean, they definitely can do things with technology that a plan or Kaiser Permanente probably wouldn't be able to invest in or may not be able to invest in. So it's really how do you get somebody to the point solution and back, make sure the right people are being offered it, and then their care is still being managed overall in a holistic kind of way.
Awesome. Thank you, everybody, for the feedback, and thank you for the question. All right, so I know we're running a little bit behind, so let's go ahead and go to the next slide here. Thank you, Rose. So what we did is very similarly for the scorecards that we put together earlier for the diabetes prevention program. We put together a scorecard for Moda Health program. And what we did is we benchmarked it against the best-in-class approach. So this is going to take a deep dive into each elements of the program and where the Moda Health program aligns with the best-in-class. So if we take a look at Access Provider Network, you can see the best-in-class approach, expansive network of providers available in employer's geographic region, 30-mile location, virtual support, health coaching, counseling visits, diverse provider base, DE&I, LGBTQ, providers of color, bilingual, ability for members to select provider based on preference. And we scored Moda really well on this, expanded network of providers from curated vendors, virtual and in-person options available, can select provider based on language and other preferences, addition of new specialty providers, and those are those third-party vendors which we discussed. Access member experience. So your best-in-class approach will have a digital front door with 24/7 access to care, coach navigators with clinical level background, master's level, triage to EAP, coaching, digital tools, therapy, real-time scheduling of appointments, in-person, phone, health, coaching, counseling, instant access to health coaching, 1 or 2 days for counseling. And you can see where we scored the Moda Health program, dedicated OEBB phone line and Moda Health member dashboard, Moda Behavioral Health Champions with direct scheduling capabilities, limited to members enrolled in Moda medical coverage. Then the care navigation, moving down, concierge style service, steerage to quality and cost efficient providers, real-time appointment setting, post-appointment follow-up, patient triage, and our decision support tool. Scored Moda, right in the middle of neutral. Separate Moda Behavioral Health Champions, decision support tool to aid in triage to resources in development. Initial steerage match patient to provider, champion follow-up after first appointment and 4 to 6 weeks into treatment, and then no online appointment for scheduling. Health equity, we scored Moda really well on this. Focus on DE&I, LGBTQ. We already discussed that earlier. Ability to serve needs of whole population, including underserved, pediatric, and then linkage to social determinants of health. And then Moda had providers focusing on DEI throughout provider network and point solutions. So Rose, if we want to go on to the next slide. Here's we have a little bit of a lag. All right, so, and then just the final sort of criteria, outcomes, quality of care. You see best-in-class approach, measurement of total cost of care, depression and anxiety. So again, the screening with the GAD-7, PHQ-9, show ability to have measurable improvements and reduction of symptoms. And Moda's proposal, value-based payments, includes a value-based contracting strategy incorporating total cost of care and outcomes-informed care. This is in development. Coordination with PCP or other providers, coordination back to PCP and other specialists as appropriate. And this would be one where, since this is an in-house service by Moda, you would have more of that PCP integration. So behavioral health champions ensure care coordination between provider and PCP. Unclear whether visits to a third-party network provider would have coordination with a member's PCP, and we're going to discuss why that is here in a second. Fits into the continuum of behavioral health needs, EAP coordination, digital coaching, mild, medium, moderate, etc. Provides solutions along the entire spectrum of behavioral health care, health coaching, low and moderate risk, counseling, high risk. And you can see the MODA proposal. Provides counseling for high-risk members. Point solution integration provides low and moderate risk care, digital tools, limited to members enrolled in MODA medical plan. And then just the accountability, measurement, reporting, performance metrics, quarterly measurement, reporting, performance guarantees tied to time to initial appointment, outcomes, care improvement, care experiences, and member satisfaction. And what if a lot of your best-in-class mental health solutions, behavioral health solutions will do is they'll put their fees at risk. And then this is what MODA had listed in their proposal for their fees at risk, what they would be willing to tie that around, percent of behavioral health. And I'm not going to read these verbatim just in the essence of time, but you can sort of see the big ones, percent of behavioral health providers adopting outcomes informed care, participating in the value-based care, members whose behavioral health claims paid under a value-based contract, and then decision support tool assisted by behavioral health champion, and then contacted by a behavioral health champion. So these would be more of like your engagement for the participants. And Enrique, I saw your hand up. Let's just go to one more slide because I want to go to the recommendations and then open it up for go through pricing, and then we'll do the recommendations, and then we'll get to questions. Just because we're running out of time, we have to get through the information. So MODA's proposed coordinated care for behavioral health program. And I do want to just point something out as we jump into this. You can see the $1.68 PEPM for the admin fees. We have that listed with third-party vendor networks as being part of that $1.68 PEPM. We connected with MODA earlier this week, yesterday I think it was, and they confirmed that they would not be part of the $1.68 PEPM, that they're still finalizing their agreements with third-party vendors. So that will be an outside cost, so that will be a TBD and below. But if you can see the projected annual cost for OEBB in terms of admin for the behavioral health program is right around $800,000 in claims offset to the renewal calculation. So let's go one more slide and then we will open it up for questions on this. All right. So MODA's proposed behavioral health solution, and this is very similar feedback from with the diabetes, the pre-D program. And Brad sort of hit the nail on the head when he was here earlier, is that it's got a lot of the components of a best-in-class program. It's just brand new. It just hasn't been vetted out and rolled out or piloted. So observations, considerations. MODA references point solutions and new vendor solutions as a key part of the offering, but it is still in contract negotiations with these vendors. How many providers in their network have agreed to the value-based terms? How are the total cost of care targets developed for behavioral health providers? Demand for behavioral health providers is at an all-time high. Will this solution result in better access to care, number of available providers, as well as reduced wait times? How will MODA's new behavioral health solution integrate with the member's primary care physician? They mention it. They don't speak to it. I'm going to give MODA an opportunity to speak to these questions here in a second. And then suggest developing performance guarantees and reporting metrics to ensure value for the additional administrative costs associated. So I'm going to stop there. And Erica, do you want to, I know that you wanted to provide some feedback to these, and I think Enrique's got a question, and I got a feeling you're going to be able to answer it for him. So why don't you go ahead and why don't you take us through these questions, and then Enrique, you can ask the question, and I'm sure Erica will give you the answer to that.
Yes.
And then we'll have to do some type of time check because we're already 15 minutes over. So
awesome.
Great. And I'm actually going to, I'm actually going to invite our Senior Manager of Behavioral Health, Dan Toma, to come on screen. And he would do a much better job at responding to these questions than I would. Matt, I do just want to clarify. Sorry if I was not clear. There are no additional administrative costs for the behavioral health program. All right. Dan, I know that we saw these questions when we saw the board packet come over. So we just had reached out to Matt and said that we'd like to just provide some input around the questions. So Dan, do you want to just start at the first question?
Sure. So in terms of the point solutions, we have executed the contract with at least one of them, and we're well along in our negotiations with other ones. So I'm highly confident that that will all be in place prior to October 1st. In terms of providers in the network agreeing to the value-based terms, that's earlier in development. Since we haven't figured out exactly what all of that looks like, we're at 0 right now, and we expect to have a good start on that by 10/1, but that's going to be really a process that we're going to be building out throughout the year and probably for years to come.
Yeah, and Dan, one thing I just want to add into that as well, on the progress for the moving the providers into the value-based care or value-based payments, we would be able to provide reporting on the number of providers as we do start bringing them over into that payment structure.
And hey, this is Brad. I know we want to walk through this, but I really want to make sure Enrique has a chance to voice the question and make sure that it gets worked into the answers of these. So I want to make sure that doesn't get lost and forgotten. I know we wanted to get through all the materials and everything, but I think, you know, addressing specific questions may be more beneficial than just walking through and grabbing some of these. So Enrique, did you want to just go ahead and
I just have
pose your question real quick?
Thank you. It's my first time seeing the grading or your benchmarks. Maybe it will be helpful for me as a new board member if I could get a historical context of like, where were you last year, a year before? If this is new, that's okay. I think that'll be helpful for me to understand how have we improved the system. And there's always room for growth, and I'm not here to criticize anybody. I just want to, for my own knowledge. My second question I do have, I guess maybe it's a MODA question. I know Kaiser is very involved in the LGBTQ community, and the providers do everything they can within their training, and the culture is friendly towards the transgender community. However, I was wondering, I have heard through some members, and maybe I'm wrong, but some of the MODA facilities or providers tend to have sort of like a not as friendly as culture environment towards the transgender community, and what can we do as a board about that? And you know, I can think of a big provider in Oregon, and at the same time, my third question will be, community college part-time faculty members across the state. Last legislation was to provide them with healthcare benefits, but denied them from vision and dental to the way we all want it. When I was a commissioner at the HEC here in Oregon, I requested the HEC to lobby this board and work with the governor on expanding the benefits for dental and vision for part-time faculty members across the state, because when you're a teacher or an educator, you need your hands, you need your eyes, you need those two sort of important parts of your body. So I hope that we are able to expand this with this proposals. If not, I would like to be really engaged on how we can do that, and maybe it's up to this board to lobby the legislator again and expand those services for those members of our community. Thank you very much for being patient with me today.
Thanks, Enrique. Ali, did you want to step in there?
Oh, I just wanted to briefly mention to Enrique that legislation actually did pass last session, that we do cover part-time faculty members now. That's it.
Great, thanks. And Dan, did you want to respond to Enrique's question on the LGBTQ plus providers from our behavioral health space?
Yeah, certainly. So that would certainly be feedback that we would want to hear about our providers. I haven't heard that feedback about our providers, but we are very intentional about reaching out to the LGBTQ plus community, recruiting providers from that community to make sure that we have those services available, and that we know within our network which providers identify as LGBTQ plus and are particularly comfortable providing those services, including support for gender affirming surgery and the behavioral health component that goes around that.
And Enrique, was that where your question was lined, or was it a little more broad from like a broader medical provider perspective?
It was yes, both to the observation. It's the two comments I've received from a provider that has a religious affiliation here in Oregon. It's quite popular, and I don't want to put the name out there because I'm not here to shame anybody, or I can email to the chair. But at the same time, it goes back to, yes, let's make that an objective for our organization, for our board, to continue to do that. I'm sure our friends from California are way more in advance in some of these areas, so I'm sure that they can help with some of that perspective. We're in Washington. Thank you.
Yeah, so Eric, it sounds like that's a broader, network type of question that I'm sure you guys have been working on and can formulate an answer, and maybe can bring that back to the next board meeting.
Yep, absolutely.
Then maybe
go ahead,
Dan. If I can speak real quickly to two, I think of the most critical pieces on here. First is access. That has absolutely been identified as a top priority, and really this program has been built with access in mind, and with for creating solutions to access. So the point solutions will do that. They're typically getting people within 2 to 6 days, and then the champions. The idea is for them to really have their finger on the pulse of what providers have availability, and make sure that before we give a provider name to a member, we know that provider's got availability to schedule that member in, and that we follow up with the member to ensure that they were able to get in and see that provider, and that provider's a good fit for them. We also want to work toward being able to actually do direct scheduling. That likely won't be available on 10/1, but that's absolutely a part of the roadmap for this program. And with integration with members with the PCP, as it was mentioned previously, that's something that the champions can do as well. Make sure that the primary care doctor is aware of what's going on in treatment. Also, a lot of the vendor solutions or the point solutions, that's a conversation that we're having with them in the contract negotiations, and they all have protocols in their services for making sure that primary care is looped in with into the members' treatment. We also think that the value-based contracting and the total cost of care initiative is going to incentivize providers to really coordinate with the primary care in an effective manner, because we think that's one of the key areas where behavioral health services can really help drive some savings on the medical side.
Awesome. Thank you, Dan, for the feedback and providing a response here. Robert, I know you said you want to do a time check. Did you want to do a time check here real fast? Or I know that we got about
Yeah,
we just have one slide left, I think.
Okay, well, let's
slide.
continue on, and then we'll time check after this then.
All right, sounds great. Do one more slide, please, Rose.
Actually, it's 2. I think we have a section break, and then, yeah. Thanks. So just for next month, we'll meet again in a month. We'll look at the updated renewals, medical, dental, vision all together, with that 3.4% target in mind. Talk again, kind of make decisions on plan design, optional plan design changes. The review rate impact by plan. The rate relativities is something we talked about a little bit, I think last meeting or the meeting before, but it would be something we try to cover in April. And then final decisions on all the renewals. And that's it.
Right. And Enrique, to your first question, which was a little more tactical, those are all new measures. So this is evaluating a new program, and it really is just a stoplight type thing where, Matt, as a subject matter expert, can kind of come on board and say, hey, where do we think from an expert perspective and his knowledge of all the other, vendors and the best in class features, where do we think they fit in there? So.
Okay. Well, thank you so much for the presentation and all the information. You can tell we have we'll have a jam-packed April board meeting, right? So any final comments on the Willis Towers Watson presentation and discussion? Okay. If you look at our agenda, we only have 2 other pieces, but we also have a break built in. I might suggest something unpopular, but would it be okay with everyone if we just skip the break and plow through the final 2 pieces? Okay. So Damien, are you ready to go with the stakeholder group then? Report. Glenn, can we go to the legislative update and then we'll loop back to the stakeholder group. Is that possible?
Sure.
Okay, great.
My name's Glenn Bailey. I'm a policy program development coordinator, and one of my hats that I wear each year is I really kind of a legislative coordinator for both PEB and OEB. I myself and some other staff, what we do is we identify bills each year that are going to possibly impact PEB and OEB, either financially or programmatically, analyze those bills, provide information to the legislature and our government relations staff on what the impact could be, and then we monitor them to see what is really the status throughout the session. As you may know, the session that we're in right now is a short session. It's about to end, actually. Many are saying probably this Saturday. They're going to declare sine die, which means end the session. And because it is a short session, members have had 2 bills they could introduce and 3 committee bills. And that's been kind of really packed into about a month and just around a month. So it's been pretty busy on our end. When we do look at bills, we look at them based on what we call priority. And a priority 1 bill would be one that would directly affect PEB or OEB, saying, you guys got to create a new program. There's a whole new policy you need to implement. This year, there was no priority 1 bills. A priority 2 bill would be bills such as benefit bills, where they're requiring that a new benefit needs to be covered, or a change in, say, prior authorization that could impact OEB or PEB through usually increased premium rates. This year, we had 2 bills that we were following. One of them was a Senate Bill 1530, which would have really expanded infertility service coverage. Right now, OEB does cover infertility services, but does not cover the most expensive portion of it, which is the IVF, or they call them ARTs too. The other thing too is the bill would have really removed our capability to have our 50% cost share and what's called the benefit maximum. OEB has a benefit maximum of around $35,000 over lifetime, and we would not have been able to do that benefit maximum. So because of that, because we would be covering new services, there would not be any really, the cost sharing would be brought down. The impact of this bill was about 1.3% increase in our medical RX premiums. The bill actually ended up in the Senate Rules Committee, and pretty much any bill right now that has not made it to the House or Senate floor is probably dead. You know, those that are still in rules, I mean, they still could come out, or Ways and Means, but it's highly unlikely at this point. The other bill too is a bill that we've seen for the past 3 or 4 years. It is to really have pay parity for naturopath physicians with PCPs for services that they both have in their scopes of service. This bill would have led to a premium increase because of the increased reimbursement, approximately 0.1%. This bill made it to Ways and Means, but was never referred to a subcommittee or voted on. So that bill also died. The other really the other bill that had a premium impact on us and was a priority too was a bill to require that pharmacists offer what's called Narcan or naloxone, which reverse opioid overdoses to people who were getting opioid dosages of a certain level, or had some drugs that they were getting with that. It had a very slight impact, about 0.05 for us. But it too, because of really its price tag, ended up in Ways and Means and was never voted on by Ways and Means. So the 3 bills that really had the highest priority for us never made it to the floor, either the House or the Senate. So they're basically dead. They may come back next year. Priority 3 bills would be ones that could possibly have an impact on us, but it's usually zero or minimal impact. You know, we can do it within existing services. One bill is a primary care access bill, House Bill 4083. This really had 3 parts to it. One, it would require that 3 PCP visits per year be provided by insurers with no cost sharing. Now, they exempted PEB and OEB plans out of that portion, so that really wouldn't have an impact on it. If they had not exempted us, there would have been about a 0.4% increase on the PEB side and about a 1% increase on the OEB side. The second part is they want to promote people getting behavioral and physical services at behavioral health homes and what's called primary care patient-centered homes by really allowing where you couldn't have more than kind of 2 co-pays or 2 claims for services that are done on the same day in the same facility. And then lastly, they require that insurers have to assign a PCP to someone after 90 days after enrollment, unless the person already assigns one themselves. They can change at any time, but it really just requires that the insured do that after 90 days, which can be done with kind of minimal cost, but it is going to have some administrative burden on us. That's awaiting House and Senate votes right now. Lastly, one of the others is it's going to require that if you're in labor and delivery, that if you're turned away from a hospital due to, say, there's another COVID outbreak or a public health emergency, that the insurer needs to cover you, transport you, but also cover you at an out-of-network facility. This had kind of an indeterminate impact on us. Our consultants weren't able to really nail down an exact impact on us. But even if it was, it would be pretty minimal, actually. And then lastly, there was a technical bill related to reimbursement for a service that insurers currently provide, which is in-home newborn visits, nurse visits. And they are going to be putting together some rule language on the level of reimbursement. Those are really the bills that we've been following. You know, there's been about 20 bills overall that we have followed in some form. Good deal of them never made it through. There's a number of bills we also follow where they really don't affect PEB and OEB, but they have a relating clause, which means they could say relating to health. And we need to watch it because when you have broad relating clauses within legislation, it means they can add anything related to healthcare in there. So you do need to watch that throughout the session. Are there any questions?
I don't see any, Glenn, and thank you for the concise and just informative report. It sounds like everything went really, well, right? So, congratulations.
Easier to explain than the out of pocket maximums or things along those lines. So.
Yes. Okay. Thank you, Glenn. Damien, you ready?
Yes, is my audio working this time?
It is.
Great. I'll make this brief so we can finish up hopefully on time. The OEB stakeholder group, Ali and I began meeting with them initially a little over 2 years ago. And really that first year was more about education and fostering a dialogue around everything OEB. The group itself has goals that are very aligned with ours, and they have 3 main goals or ways to achieve that goal. Continually learning about the programs available through OEB, increasing the two-way communication between their constituencies represented in the committee and the OEB staff and the OEB board, and then also regularly reviewing and providing input to OEB staff on any existing and future decisions around health benefits. So, like I said, the first year was really spent fostering that relationship, including giving presentations to get everyone on the same footing with Insurance 101, and then an overall overview of the OEB renewal process. The group itself has representatives of 7 different associations that offer benefits through OEB. COSA, the Coalition of Oregon School Administrators, the Oregon Association of School Business Officials, Oregon Community College Association, Oregon Education Association, Oregon School Boards Association, Oregon School Employees Association, and Oregon School Personnel Association. So you can see it's a pretty valuable group to have a strong relationship with. The latest meeting we had, Ali went over what was a summary of our last meeting, the last board meeting, to answer any questions they might have, to translate things they didn't understand because they don't live in our world every day. And also we explained at a high level what the purpose of a COE would be and why we were looking at that, just to get them thinking about that in terms of, if we do develop it, what are some things we should look out for, what were concerns that they had. So we got some valuable input from them, and we'll continue to meet with them a few days after each of these board meetings to explain how things are going through the renewal process, so that we can answer any questions they've got. Now that Georgianne Helmuth is on board as our licensed agent on the staff, she has been meeting with them quite regularly, because as she hears things, meeting with different districts or different entities, she's running it by them to see if this is common, if this is isolated. So it's been a real good check for her. And also they are giving her a lot of leads in terms of which districts or which areas need information, need help, understanding exactly what OEB is offering in different areas. So
that really is a summary of where we're at to date. We meet with them in just a couple days to go over this last board meeting. And with that, I went through it pretty quick, but are there any questions?
Damien, I do not see any questions popping up. There are no hands
Okay, there you
raised.
go.
Okay. Well, thank you, Damien, for that. So we are ending up right on time. I appreciate that, everyone. Rose, do we have any public comments?
No, no public comment.
Dang it. Maybe next time. All right. Anything else for the good of the order? Yeah.
Yeah, can we talk about timelines or what we're looking for as the mask mandates go away, the state of emergency goes away in a few weeks, et cetera?
Yeah, I can talk about that, JJ. They're planning on reopening state buildings May 1st. They haven't moved that up yet, so that would be the earliest we could consider moving meetings back to in person. I think, you know, as we briefly talked about the other day, Rose will look into options, whether it's, you know, whether for the board to decide whether they all want to meet in person or have a hybrid kind of model where folks could meet virtually as well as at our normal boardroom, or any other options. So it'll take us a little while to put that together, but with the board not meeting July and August, you know, it could be something that, you know, we don't change anything for one meeting and we change it, you know, in the fall or something, but that's kind of where we're at.
Anything else on that, JJ?
I'm perfect, thanks.
Okay. Ali, I have a question. Is it correct that we usually just schedule in 2 April meetings just in case? Or is that not true?
Do for final decisions and then a second quicker meeting to approve the rates, the premium rates.
Yeah.
Yeah.
I just wanted to put that out there for our 2 new board members that we might have a follow-up meeting sometime in April if we can't get everything done in the next meeting.
Yeah.
Okay. All right. Anybody else? Well, I appreciate your time and your effort. The questions were awesome today and the discussion was equally good. I appreciate it. And as you can probably tell, we're going to have a pretty busy schedule for April, and I look forward to seeing you then. Thank you, everyone.
Thank you.
Thank you.
Bye.
Thanks, Ron. Bye. Thank you.